I'll tell you. I'll introduce you. If you want to, you can just sit like at that head table over there. Or if you want to, if it's more comfortable with your regular seat. Okay. Wonderful.
Remote for down there?
We've got the remote for down there.
For down there, okay. Should I just put it down there?
He said just leave it up here since we're all going to speak up here.
Oh,
But
okay.
if you want to turn it around and do this.
No, because we have that.
He finds it. If everyone will have a seat, we'll get started. Good morning, everyone. My name is Pat Brooks with CMS, and I'd like to welcome everybody to the ICD-10 Coordination and Maintenance Committee meeting. And this is a very exciting week because we are ready. We have cheers in the audience because a week from Thursday, we will be finally implementing ICD-10. And I should probably applaud all of you guys because I wanted to take a moment to express all the appreciation that CMS and CDC have for the many organizations that have regularly come to these meetings over the past 2 decades to help us develop and refine ICD-10-CM and ICD-10-PCS. We have a very knowledgeable coding group that participates in these meetings twice a year. And it's based on your recommendations, discussions, hard questions, and good comments that I think we are where we are today, and we are so close to having ICD-10 ready to be implemented. We also acknowledge, just as with ICD-9-CM that was implemented in 1979, that wasn't a perfect system, and we continue to update it through all those years. And Donna Pickett from CDC is laughing. And I know Maddie Hugh and I from CMS frequently get a chuckle out of people discovering something in ICD-9-CM 30-some years later that was an error that no one noticed for all those years. So I think we can be prepared that the same thing will happen with ICD-10 as we use it more. We're going to see areas where refinements and improvements are needed for today's world. And we will definitely, as medicine's changing much more rapidly than it was during the 1970s, we expect that this committee will be quite active in updating the coding system, and we welcome your recommendations for doing so. We have no speakers today on overview on ICD-10. We've had many, and we've had many nice outreach sessions. And I would also like to take a moment to thank 2 people in the audience here today, Sue Bowman from AHIMA, and Nellie Leon Chussain from AHA. I hope many of you saw the last thing they did for us. They've been quite helpful in doing ICD-10 outreach. They speak clearly. They speak to coders in a way they understand. They also speak to physician offices in a way they understand. We had a very successful ICD-10 teleconference on August 27th. We had over 20,000 people registered for that call. It was extremely popular, well received, and thanks to those 2 in particular who provided good basic information on ICD-10. Now, I know most of the people in the audience today and listening to live stream are knowledgeable about ICD-10, but if you still feel like you need some educational material or outreach, we would encourage you to look at ICD-10 website for CMS, and you will see some fact sheets. You will see the call from August 27th. You can listen to that audio session. You can also look at a couple of Sue Bowman's previous ICD-10 basics and ICD-10 more basics, which I found to be particularly excellent, particularly maybe for those new to coding, where she tells you simple things like how to look up in the index and how to find a code. It sounds maybe basics to those participating in the audience, but those who are new to coding and faced with ICD-10 implementation have found these things to be right on. They're very helpful. And we will also be posting a link in the near future for a post-implementation call that we will have once again, where we'll feature our stars, Sue and Nellie, talking about helpful hints after implementation. So as things come up and you think little hints that you think might be useful, if you want to send the three of us an email saying maybe you should cover this, or this is an area of concern issue, global things. They won't be going through coding questions, but we hope to do whatever we can to help the industry implement ICD-10 smoothly. I have another announcement. It's a sad announcement. Celeste Beauregard, please stand up so the people in the audience can see you, who you have loved working with for the past 5 years and who's been critical to many coding requests that you've had and to working with us on many coding and DRG issues. She's decided to take a little break from government work because all this ICD-10 stuff is wearing us all out. And she's just such a pleasant person, those of you who have worked with her in the past, and we will greatly miss having her. So I don't know how we're going to manage, but we're going to try to do our best. And you'll be meeting later this morning a new member of our team, Choma Obi, who's going to be trial by fire this morning, doing her first coding proposal, and you'll have to all be very nice to Choma. Now we'll turn to our first slide. And you can find on page 9 in your handouts, those of you who are following along, we'll go over some basic introductions about the committee. The ICD-10 Coordination and Maintenance Committee is a public forum, as we all know, on ICD-10-CM and ICD-10-PCS. We meet to discuss proposed updates and to give you and the audience here a chance to ask questions or make suggestions. Other people on the phone or listening by live stream can follow what's happening, and they can hear the issues that others have raised. This morning, I'll be leading the procedure part of the discussion, chairing that part of it, and we have a number of topics withdrawn and postponed to later meeting this morning, so we expect to finish the procedure part before lunch, well in advance of lunch. And then Donna Pickett from CDC will take over, and she'll continue the rest of the day until about 5 o'clock doing diagnosis issues. And just a heads up, our lunch is planned to break around 12:30 to 1:30. Then Donna Pickett will pick up again tomorrow morning at 9 o'clock with any remaining diagnosis issues. But we do plan to finish our procedure issues this morning. Now we will be presenting proposals this morning and giving those in the audience a chance to ask questions or comments. But I have to point out, as we do at every meeting, we make no final decisions at this meeting. So if you hear CMS said we agree we should create this new code, or we recommend no new code, that's for discussion purposes. That's our evaluation based on what we've done, and we hope that you will have your own comments and suggestions. Some of you make comments at the meeting, think about them later, and then you send written comments. Maybe you change your mind later. We appreciate that, because these are complicated issues, and sometimes after you give it some thought, sometimes you have a different opinion. So we encourage you all to ask your questions and comments. Now you have to send your written comments, and these are extremely important. If we were to have a request for a new procedure code for a new technology, there are none at this meeting that want to be implemented April 1st, 2016. If there were, you would have had to comment October 16th. All the codes requested at the meeting today are under consideration for implementation on October 1st, 2016. So your deadline for submitting comments is November 13th, 2015. Once again, November 13th. And if it's a procedure code issue, you need to send it to me, Pat Brooks, at the email address that you see. And if it's a diagnosis comment on diagnosis topic that Donna's going to be leading discussion later today, you send it to Donna. Now, we all know that we've been faced in the past few years with the partial code freeze. And so we will be implementing ICD-10 on a week from Thursday, October 1st, 2015. There were some new codes added from the procedure side that will be added for those October 1st, 2015 updates, but they were only for new technologies. There were no new diagnosis codes added for this most current release, so Donna did everyone a favor by keeping things extremely stable. But the good news or the bad news is that the freeze will end October 1st, 2016. And I know there are a lot of people concerned about what's been held up all these years as we've applied the criteria of no new codes during the freeze, except for new technology and new diseases. Just a little historical context when you're looking at the codes that would go into effect October 1st, 2015. We had a proposed rule that included codes that were finalized, and they were included in the proposed rules. It didn't include the March C&M code proposals. And in August 1st, 2015 final rule, we included all new codes that were added to the ICD-10 PCS that were going to be implemented on October 1st, 2015. In June of this year, we posted final code updates and addendum. So we've been posting ICD-10 files every year. This is the real one. This is the one we're working from. So hopefully everyone, I'm sure everyone in this audience has seen them, but if anybody else has not seen them, we give you links on CMS's website for your convenience. We post both the diagnosis and procedure codes on the link I give you. Or you can go to CDC's webpage at the link we show you, and we post the ICD-10 CM files. Poor Donna yesterday was getting ready with a massive agenda to get ready, and she had a server fail yesterday, so be impressed that she's so organized here today and has everything ready. But it's good to sometimes, if you can't find our server sometimes fails too, or files posted, the links don't work, and then we have to re-hook them up. So you have two places to look for some of these codes. In June of next year, we plan to have the final code updates and addendum posted. Now, we also have tools, that the general equivalent mappings and the reimbursement mappings, that I think people are using to a lesser extent than they were when we were trying to convert a lot of payment policies and other things. But we had made a commitment to keep those files going for at least 3 years after implementation of ICD-10. So we posted the most recent ones for 2016, and we'll have the annual updates for next year by August. Our next Coordination and Maintenance Committee meeting will be March the 9th through the 10th, 2016, and the deadline for requesting a topic is going to be January 15th. So if you want to have a new procedure code added, you need to send the request to me by January 15th. If you want a diagnosis topic, you need to send the request to Donna Pickett. At this meeting, you can participate in one of 3 ways, and people have loved this. You can come to the meeting, and we're happy to see you here. You can also listen through the free conference lines, and some people do that while they're sitting at their desk working. Or you can participate through the free live stream webcast, and people really have enjoyed that because they can see all the slides, they can hear the presenters, they can hear the discussions. And for friends and coworkers who aren't here today or can't listen, we do post those videos later on our website, so you can watch later, or you can re-watch something if you wanted to see it again. And the conference lines are posted. And that takes a couple of days to have all those reposted from the meeting. And so we hope that having these 3 ways to participate gets more people involved and gets us more comments and questions about the proposals. But no matter how you participate, please remember we need your written comments. We love to hear the comments at the meeting, but we even more appreciate your sending your written comments to us, in this case by November the 13th. And once again on this slide, I show you who to send them to. I mention that because frequently after the meeting, Donna will get my procedure code comments from someone, and I'll get her diagnosis comments, and it's good to send them directly to them. And we tell everybody to do this electronically because we don't even provide our mail address anymore because there's so many delays by going through the mailroom. So send us your electronic comments. I post this information about the code freeze we had that you can read at your leisure, but just be aware that we set up a code freeze because everyone needed to be ready for implementing ICD-10, and then we had several delays. And because they wanted some stability while we're converting systems, while we're doing educational material, we've kept the code updates to an absolute minimum based on that criteria of new diagnosis and new procedures. And just a little bit of history now, the last time we had a regular code update was October 1st, 2011. And that's when we had a lot of ICD-9 codes and ICD-10. After that, with this strict criteria, I think you would call just a handful of codes that update each year. So we have provided a lot of stability. And so this October 1st, 2015 is the last year of the partial code freeze. As mentioned before, we do have some new codes. They're only for new technologies. There were none for diagnosis. Next October 1st, 2016, we will be implementing the codes that we discussed at all these meetings during the partial code freeze, and we said we'll wait until after the freeze. Those will be implemented, as well as any for this year that are submitted and approved based on comments. So that could be another banner year, October 1st, 2016. We'll now turn to our procedure parts of the topic. Oh, and Nellie, do we have any questions or comments?
Good morning, Nellie Leon, Chisane American Hospital Association. We're very, very glad ICD-10 is finally here. And so we're already thinking about the future, and after 5 years of a partial code set freeze and having come through here, we realized that there's probably a lot of new codes and revisions and lots of new exciting things to look forward to next year, which brings me to my request. Given how much work has been required of payers and providers and software vendors and everyone else, I would like to make a request to have the addenda, even if it means having to split it into 2 addenda, if you could provide us, and by you I mean CDC and CMS, provide us a partial addenda at the beginning of January so people have a chance to study it and start making plans and make the necessary changes, realizing that there is a March Coordination and Maintenance Committee meeting, and there's a possibility that some more codes could be discussed that you feel merit implementation that October, and perhaps then adding those codes later. But if we're talking about hundreds of new codes come October 2016, the lead time that you can provide the healthcare field would be very, very much appreciated.
Thank you, Nellie. I think Don and I both can say that we'll consider that, and we'll see if it's possible for us to share these early, and then we'll let you know by the March CNN meeting if that takes place. So thank you. That's a very good point. Does anybody else have any question or comments on the general part of the meeting? If not, then I'm going to turn the meeting over to Maddie Hugh, who's going to go through our first 2 procedure topics. Maddie?
Thank you, Pat. Good morning. If you're following along in the handouts, we're on page 12. And this topic might look a little familiar. We presented this back at the March meeting, and the focus at that time was on the fenestrated and branch endograft repair of the abdominal aortic aneurysms. And the focus on that continues today. But in addition to that, you might remember that some of the comments that were made at the March meeting were about upcoming technologies that relate to repair of the thoracic aorta as well as the common iliac arteries. So we're bringing this back for further discussion, and I would like at this time to welcome Dr. Matthew Seidman.
Good morning. Thanks for having me back. I had the privilege of speaking here in March on this same topic, and we're going to cover some of that again today. So as Maddie introduced, my name is Matthew Seidman. I'm a vascular surgeon at the University of Texas Health Science Center in San Antonio. I'm also the chair of the SVS Coding Committee, and I'm here representing them. I also serve as the RUC advisor for the SVS. I have no financial conflicts or disclosures. So let's talk about abdominal aortic aneurysms. An abdominal aortic aneurysm, or a AAA, is a dilation of the aorta to 1.5 times greater than its normal diameter. When they grow too big, they can rupture, and that's a catastrophe. That's bad. There's about 15,000 deaths annually in the U.S. due to abdominal aortic aneurysms. So we want to fix them when they're small, before they rupture, not when they're large. The small ones have a lower risk of rupture, and sometimes we'll watch those when they reach a break-even point where the risk of death from the size is large. That's when we want to fix them. There's two ways to fix aneurysms. The standard open repair is traditionally been the gold standard, where there's an open surgery to repair the aneurysm, remove the weakened part of the wall, excise the sac, replace it with a graft. That's not what we'll be talking about. What we're going to focus on is endovascular repair, which has actually become the more common way to repair aneurysms over the last 15, 20 years. An endovascular repair is where we use an endograft or a stent graft that's inserted through the femoral arteries under fluoroscopic guidance to redirect blood flow away from the sac and depressurize the weak part of the aorta. This is, again, what's called EVAR, or endovascular aneurysm repair, and it's much better tolerated by the patients than the standard surgical approach, which can be a very stressful operation and some patients just can't tolerate. There's many different types of endografts out there. We're going to touch on several of them. The simplest would be the tube endograft, which is just a straight piece, a straight tube that's put inside the aneurysm used to treat an isolated abdominal aortic aneurysm. These are very seldomly seen these days. What's much more common is the standard bifurcated endograft, which is a covered stent tube that bifurcates into each leg. Now, these can either come pre-bifurcated, they can come in pieces that are referred to, you might see in the op note, as limbs, or they're called extensions, but they're basically pieces that are assembled in vivo under fluoroscopy to exclude the weak parts of the aorta. Standard EVAR is great for standard infrarenal aneurysms. The topic of FEVAR comes up when we are dealing with juxtarenal and suprarenal aneurysms. So if you look at these pictures, at first glance, they kind of all look the same, but they're very different. And the difference has to do with where the aneurysm is in relation to the renal arteries. Because for these EVARs to work, they're covered stents, and they have to shut off the blood flow to areas of the aorta or areas of the artery outside the stent. And if you wind up covering the renal arteries, or worse, the superior mesenteric and celiac arteries, as you can see, well, that creates bad problems for the patient, so we don't want to do that. You got to keep blood flow to those key arteries. So on the first picture, you can see infrarenal. There's normal aorta below the branch vessels before you get to the aneurysm. With a juxtarenal, the aneurysm extends right up to and includes the origins of the left and right renal arteries. And then a suprarenal artery not only includes the renal arteries, but includes the superior mesenteric and the celiac arteries above, creating significant challenges and complexities for the treating physicians. So there's four key branches off the abdominal aorta that we have to worry about when we're fixing aneurysms. The right renal artery, the left renal artery, these obviously take blood flow to the kidneys. The superior mesenteric artery takes blood flow to the intestine. And then the celiac trunk gives rise to the common hepatic, the left gastric, and the splenic, basically taking blood flow to the liver, stomach, and spleen. There's actually a fifth vessel off the abdominal aorta, the inferior mesenteric artery, which takes blood flow to the distal colon. This vessel is well collateralized, and it's been shown for years that this is not clinically significant and can be covered. So, I'm going to give a disclaimer before I start talking about this slide. What I'm going to discuss on this slide is off-label use and not FDA approved, but this is clinical practice, real world, and so you'll see this in op notes, and so we thought it was important to discuss. To treat some of these problems where you have aneurysms encroaching upon major branch vessels, physicians have gotten quite crafty. It's probably a good way to put it. Resourceful is another way to put it. But basically, we've come up with several ways to use the stents we have available to us and kind of extend their efficacy and treat these challenging situations while maybe off-label, but better for the patient, avoiding a much larger operation that they may or may not be able to tolerate. And so you may have heard or seen in op notes chimneys, snorkels, and sandwiches. This is an example of what that is. It's basically taking other stents and putting them either adjacent to a standard EVAR graft, between pieces with a snorkel, or sandwiched between other pieces to maintain blood flow into those branch vessels, be they renal arteries, the celiac, SMA, etc. So there's basically two types of what would be considered FEVAR or fenestrated enografting. There's branched and fenestrated enografts that were basically developed to treat these situations without having to be creative. A branched endograft has actual little nubs of graft material sewn onto the endograft that are then directed into the branched vessel that we're trying to preserve blood flow into, whereas a fenestrated endograft has just a hole in the material that you line up with the branch. So looking a little closer at that, this is a picture of one of the branched grafts, and you can see the branches, the little nubs pointing off the main graft. This is then oriented, and covered stents are inserted through these little branches into either the renal, the SMA, whichever branch off the aorta we're trying to preserve, to maintain flow into those branches. With a fenestrated graft, you have the same approach, except that there's no little nub of material. There's just the opening in the graft that you have to appropriately orient to the branch, and then you stent through those into the branch. I want to point out that there's a difference between branched endografts and bifurcated endografts. So when you're reading op notes and coding, branched endograft refers to these little nubs that are specifically designed to treat the major branch vessels off the abdominal aorta. Bifurcated refers to the endografts dividing into the right and left iliac. So a endograft can be branched and bifurcated. It can be bifurcated and not branched. It can be branched and not bifurcated. Okay? If that makes sense. I see Nellie shaking her head. That's not good, right? Okay. How about the FEVAR procedure itself? Okay, it starts off kind of like a standard EVAR, but it's much more complex. It takes longer time to perform, and there are many additional steps. Like an EVAR, it starts with femoral access, whether that's percutaneous or cut down. Access is gained of the femoral arteries on both sides. Catheters are placed up into the aorta from both sides. The main body of the FEVAR device is deployed and then properly oriented to get either those branches or the fenestrations lined up with the major branching vessels off of the aorta. You then have to catheterize through the fenestrated or branched graft out into each of those branch vessels, and then covered stents are placed through the branches or fenestrations into the branched vessels. Once those are all deployed, then the remainder of the aneurysm is fixed with bifurcated limbs or extensions into the iliacs in the standard fashion. I want to point out that when we say these covered stents into the branch vessels, that it's actually the opposite of what you would normally think with a stent. Normally when we talk about stenting, we talk about dilating a stenotic or occluded vessel to reestablish blood flow. This is actually the exact opposite. In this procedure, we're using stents to bridge the gap between the graft and the branch vessel. We're not opening an occluded artery. We're using the stent to maintain flow to an artery that's already patent. So a little bit different concept, but the term stent is still used for both. Another problem that we have in this area is anatomic boundaries. And so sometimes an endograph will cross an anatomic boundary from one segment of the aorta into the other, either for therapeutic or procedural reasons. So it could be due to the nature of an aneurysm, so that we can have thoracoabdominal aneurysms, which spread from the thoracic aorta into the abdominal aorta, which then can present some coding problems, not just surgical problems, but coding problems of is it thoracic or is it aorta, because there's not really a code right now for thoracoabdominal. That's something we're talking about on our side with CPT, and I'm sure it's going to also be an issue with ICD-10 as well. So sometimes we'll do that because the aneurysm itself crosses boundaries, but then other times we'll do it where the aneurysm is, let's say, a suprarenal aneurysm, so the aneurysm is all in the abdominal aorta, but to get a landing zone, so when we put these stents, we have to have a normal landing zone, so normal aorta above and normal artery below the aneurysm so we can seal. So you'll see seal zones, landing zones in the opnope, and that landing zone may be in a different anatomic region. So the proximal landing zone could be in the thoracic aorta, even though we're treating an abdominal aortic aneurysm. Just pointing things out, not necessarily offering solutions, but pointing out. So what's next? Right now, fenestrated endografts are FDA approved for treatment of the abdominal aorta with up to the 4 branches. Coming down the future, we're looking to treat the entire aorta. So you'll see branched and fenestrated endografts in not only the abdominal aorta, but the thoracic aorta and the pelvis, with the goal of eventually being able to successfully treat the entire aorta from the aortic valve to the iliac arteries endovascularly. The next one you'll probably see is branched iliac endografts. Right now, the standard EVAR, as we showed, it's bifurcated into both iliac arteries. Those usually terminate in the common iliac arteries, but sometimes there's aneurysms of the common iliac that extend down to the iliac bifurcation. Currently, most of the time we wind up having to cover or occlude the internal iliac artery to seal an aneurysm. But very soon we'll have technology where there'll be a branched iliac endograph where we can stent into both the internal and external iliac artery. So you should be seeing that within the next year or so. And then also coming down the line is branched and fenestrated thoracic endografts. Currently, the thoracic endografting, or TVAR, is being performed in mostly the straight descending thoracic aorta. But as the disease and disease processes creep up into the arch, it encroaches upon the pre-cerebral vessels, so the innominate, the carotid arteries, subclavian arteries are involved. And so I think very soon we'll see branch or fenestrated endografts to treat the thoracic aorta with the left subclavian and even innominate and common carotid arteries. So hopefully I've cleared stuff up and haven't made it more complicated, and I'm happy to answer any clinical questions.
If anybody has any questions, please come to the microphone and state your name. Just in case something comes up. Okay, we'll now turn to the coding options. We're on page 14 of the handout. If you're following in the handouts, you can see the tables that display the way we would currently code branched or fenestrated endograft repair of the aneurysms. And obviously, the whole reason we're here is because these codes don't allow differentiation between the standard EVAR repairs or the branched or fenestrated. And for those of you that remember, we had a proposal at the September 2012 CNM meeting to revise the table for the thoracic aorta body part. So that is shown here, where we were going to revise thoracic aorta to thoracic aorta descending and add a value X for thoracic aorta ascending arch. Coding option 1 is to not add a new device value to table 02V, restriction of heart and great vessels, or table 04V. You'd continue to use the existing codes as shown in the current coding tables. Option 2 involves adding a device value of E for intraluminal device, branched or fenestrated, to the root up restriction in table 02V and 04V for the thoracic aorta, abdominal aorta, and common iliac artery body part values. This option would also add a qualifier bifurcation to the existing second row in table 04V to identify endograft procedures at the aortic bifurcation, as Dr. Seidman was just describing. And then separate codes to identify the placement of stents into the branch arteries could be assigned pending further discussion. Those are the tables. Coding option 3 builds on option 2, and it adds the number of arteries to the device value. So in this option, it eliminates the need for coding stents separately. So you would have a new device value of E for intraluminal device for 1 or 2 arteries, and F for intraluminal device, branched or fenestrated 3 or more arteries. And those are the tables. And I just want to emphasize again that we brought this proposal back for further discussion. The emphasis continues to be on codes for fenestrated grafts of the abdominal aorta, but we felt it was important to put out there the upcoming technologies that will become available very shortly in the near future for the thoracic aorta as well as the common iliac arteries. Right now, CMS is recommending option 3 to become effective next October. And I'd like to go over the interim coding advice real quick. We would ask that you continue to code endovascular repair of aneurysms for the abdominal, thoracic, or the common iliac arteries that use fenestrated or branch grafts with the appropriate codes from table 02V and 04V, and to also assign the separate codes for stenting of the branch arteries to table 04H and 047. For insertion of lower arteries, these codes would be reported to identify stents that are inserted when the medical record documentation indicates that the arteries are normal or there's no documentation of any stenosis or stricture in the arteries. And then very rarely, for the dilation table, you would report the appropriate codes if there was documentation that there was stenosis or stricture in the branch arteries. Do we have any comments or questions?
Jean Yoder, contractor at the Defense Health Headquarters. On your option 3, you have the add E intraluminal device. You might want to consider putting, instead of a comma there, a semicolon, because then, though, if you look at it long enough, you know what's going on. Because if you're at the bifurcation, you automatically have 3 arteries, okay? And so just to make sure that they understand that the branch and fenestration are the 1 or 2, if you put a semicolon, just a suggestion, I don't know. I mean, if you look at it long enough, you can figure it out.
Okay, you can send those in written, Jean?
I'm Linda Holtzman from Clarity Coding. In the interest of full disclosure, I worked on part of this proposal. I wanted to respond to Jean and also make another comment. On page 16, with option 3, the proposal is to add a device value, intraluminal device, branched or fenestrated 1 or 2 arteries. That would just be for those arteries that are branching off the aorta. If you then want to show that it's bifurcated, that's where the qualifier comes in. So I'm not following your comment. Right, but you wouldn't be counting the common iliacs.
Jean, could you go to the microphone just so everybody could hear?
If somebody doesn't understand what's going on, and they're saying, okay, yeah, I see this bifurcated, but it says intraluminal device. And so you're saying, well, the intraluminal device, how many arteries do I have coming off of this? Well, you've got the two common iliac are coming off, even though it says bifurcation over here. Never mind, it's okay. It was just a suggestion to put a semicolon here, because then you would know that the branches or fenestrations are the things that you're accounting, not the bifurcation, not the bottom.
How about we take that up with coding clinic?
Yeah, that was actually going to be my thought, that, after Dr. Seidman took the trouble to point out that there's a difference between bifurcated, which goes into the common iliacs, and branched, which is coming off the aorta on the sides, so to speak, that it's probably best to clarify that point through coding clinic, that if it's branching, quote unquote, into the common iliacs, that's where the qualifier for bifurcation comes in. So my other comment is just to point out that we currently, for the next week, which makes me happy, do have an ICD-10 code for fenestrated and branched. It's 3978.
Yes.
Right? So I just wanted to point out that this request is really to restore detail that we have now that's currently missing in ICD-10. And so we'd restore the detail and also provide more detail in being able to show the number of branches that are coming off. I also like option 3 because that cuts down on the total number of codes, which anything we can do to simplify this, I think, is a good idea.
Thank you, Linda. I know it's a lot to absorb right now, so take your time, and just one more additional coding consideration slide. As Dr. Seidman discussed, there's a lot of coding issues to figure out as far as endografts that cross the anatomic boundaries and the additional graft extensions. So we're extremely interested in public comments on tackling these coding issues. And again, please submit your written comments by November 13th. Are there any additional comments or questions? Okay. We'll move along to page 17. Our next topic is cerebral embolic protection during transcatheter aortic valve replacement. Currently, there is not a unique ICD-10 PCS code to identify the use of cerebral embolic protection systems during transcatheter aortic valve replacement. So today we'll discuss if a new code should be created. I'd like to introduce Dr. Samir Kapadia to present the clinical portion.
Just a moment. Thank you. Thank you very much. I'm Samir Kapadia. I'm director of the cath lab at Cleveland Clinic, and I'm going to discuss some of the important advances in the field of cerebral protection at the time of transcatheter aortic valve replacement. The topic that we are going to briefly discuss today is in this format, that which is the patient population that we are studying, what is the unmet need, what is the technology that is available for this particular purpose, what are the randomized clinical trial and additional clinical information, and why we think that it is important to track the outcome of patients who are using the emboli protection devices during TAVR. TAVR is transcatheter aortic valve replacement. So if you look at this, the aortic valve is the main valve that takes the blood out of the heart to the whole body, and in about 5% of the population above the age of 75, this aortic valve gets narrowed to the point where instead of a size of a quarter, it becomes size of a pen, and we need to replace the aortic valve. Almost until about 2002, when the first transcatheter aortic valve was performed, all these valves were replaced surgically. meaning opening the chest, stopping the heart, and sewing the new valve in. Now, what we are doing for last 12 years is gradually replacing the aortic valves with a transcatheter mechanism, meaning that we are not taking out the old valve, which is calcified, but actually placing a new valve inside of the old valve, which is either balloon expandable, meaning that we put a balloon and we expand it, or we put a nitinol valve inside of the old valve and push the old valve to the side. What happens, I don't know if I can play that movie, but there is no way to click on this particular movie. But the idea is that the valve is placed from either the subclavian arteries or from the femoral arteries or from the apex of the heart, and it goes inside of the old aortic valve and it expands. When you expand the aortic valve, what happens is that the calcified aortic valve is pushed to the side, and some of the material from the aortic valve may get loose and can circulate in the body and may go to the brain or other organs of the human body. So that when the first paper was published, this was an experiment that was done, which is no longer going to be possible to be performed again, where 179 patients underwent aortic valve replacement and another 179 patients did not undergo aortic valve replacement despite severe aortic stenosis because they were not operative candidates. And these 350 patients were followed for 5 years. Very interestingly, at the end of 5 years, all 179 patients who did not undergo aortic valve replacement passed away. But the patients who underwent aortic valve replacement, they did very well, but there was a 5% stroke risk. And this was the article that was published in New England Journal of Medicine, and then now recently in Lancet. Both of these show that the most important complication of this procedure was stroke. 5% of the patient had major stroke. And Dr. Schaff from Mayo Clinic wrote this editorial saying that this is something that we need to address if we are going to do transcatheter aortic valve replacement. We looked at even this second generation valves. So this was the first generation valves. These were bulky, they were placed relatively in a primitive way. And now when we go to the second generation valves, and this is the meta-analysis that we performed, we still have 2.8% stroke risk. So 2.8% sounds like a smaller number, but still 3% of the people, if they develop stroke, this is the whole reason we are replacing the aortic valve in this elderly population is to give them quality of life. To have a stroke is such a non-starter for most of the patients that they do not want to have this procedure if they are going to have stroke. They would rather die but not have stroke because they don't want to be burdened to their family. So stroke is a major impediment to generalizing this therapy in the population. And stroke is not just the stroke, but even the TIA, which is transient neurological deficit, has now been shown to have a mortality impact, meaning that if people have TIA or stroke at the time of procedure, they are less likely to live as long as people who do not have stroke or TIA. And this is the article that we are going to have it published in Circ Intervention very soon. And what is clinically relevant? Of course, if you ask the patient is distressed by the fact just the word stroke is distressful to the patient and the family. This is the first thing that whenever you see the patient, they want to know that am I going to have stroke? I really don't want this procedure. I would rather die. So if you look at the clinical stroke, there's major stroke, minor stroke, and these are divided by the NIH stroke criteria. There is also a neuroimpairment, meaning that there is a TIA or silent brain ischemia. TIA meaning that the neurological event resolves as far as we can tell in the patient. So they're not able to eat their food, but now they're able to eat their food. That's the kind of neuroassessment that is done for the TIA assessment. And then, of course, there is a brain infarction. Brain infarction meaning that there is a MRI evidence of brain death, but either the patients recover from that or not, but the brain is definitely damaged in certain parts of the brain. How does it look like? So this is a typical picture of an MRI. So this is on the left side is as you can see, there is no lesion, and on the right side, the white spots are seen where the water cannot diffuse into the brain. So this is called DWMRI, and this shows the brain infarct. If you look at the arteries, you can see the arteries that are occluded by the debris that gets loose from the valve or from the aorta and occludes the arteries of the brain, and then they cause the infarction. What does these infarctions do? So one, they can cause a focal stroke where language, memory, motor skills are impaired, or they can cause multiple small infarction, and this multiple small infarction can lead to attention deficit, memory deficit. People say that they are not as same as they were before. They cannot calculate. Reasoning is impaired. Processing speed of the brain is impaired. They cannot recall words. So this is a very typical finding of multiple small infarction where neurocircuitry in the brain is impaired and they cannot communicate with each other. And this is a diffuse white matter changes. When does the stroke happen? When you replace the aortic valve. So as you would anticipate, it happens immediately after you do the procedure, in the sense that while you're doing the procedure or just after the procedure, you recognize that the patients are not able to wake up. If it's done under general anesthesia, it may take a day to recognize, because these older people, by the time they come out of general anesthesia, it takes some time to recognize it. So in the first few hours to about 2 days, most of the strokes are recognized. There is small number of strokes that happen afterwards, probably related to some thrombus formation on the valve, but that is not the most common kind of stroke. Most common kind of stroke happens at the time of procedure. And now there are several papers showing that the stroke risk is highest after the procedure. And where do they come from? As I said, they come from the valve itself. As you can see in the bottom, the valve is extremely calcified, and it's a friable tissue. And if you see the surgery and if you see this valve, it is amazing that why it just happens in 3% of patients. It should happen in almost all patients if you see these valves. But, and I'll show you that in the MRI it does happen in most of the patients, but 3% of the patients get a neurological deficit. And of course the aorta is calcified. The same process that gets calcium on the valve is also on the aorta. There is a lot of recognition of the fact that now the stroke has to be redefined. The stroke is not just a clinical stroke, and silent brain infarction is the term that the AHA, American Heart Association, has suggested for being used, because there is enough evidence to say that these so-called silent are not really silent brain infarction, because if you look hard enough with neurocognitive analysis, with depression, word finding abilities, higher functions of the brain, then you can really find that why the people are not doing as well is because of this brain infarction. So SBI, silent brain infarction, is now a common terminology. And they are not that silent, as I said, that they are associated with more disabling strokes in the future, because if you have another stroke, then because of these prior strokes, you may be disabled more. And this is seen in younger and older, more than 75 or less than 75-year-old patient. And also, these are also associated, even with the small infarcts, is associated with higher mortality, how long you live. It is also associated with dementia, as you can see on the other side, that the dementia is also increased almost 2 times as more common with this silent infarction, or so-called silent infarction. And how common do we see this with the TAVR procedure? So this is very important, and we see this in 80% of the patients, 60 to 80% of the patients. If you do an MRI, you see brain lesions. So if you see the brain lesions in 60 to 80% of the people, although we are recognizing by clinical evaluation only in 3 to 5% of patients major or minor stroke, this is an extremely common problem. And there are several devices that are now being used or being tested because of this. This is such a big problem that we need to have a device to prevent this material going into the brain. So there is a filter device that you can see in the bottom corner. There is a deflector, meaning that this just deflects it from coming inside of the brain, but it goes in the aorta. and these are two different deflectors available. The data that we have from there are two different versions of the Claret device, the Montage device or the Sentinel device. Both are CE marked, and this was the older one. The main difference is just the handle and not really the filter. So it's basically the same device. And they sit in the innominate artery and the carotid artery. It is inserted from the radial artery, so it's a very small device, a 6 French, size of a straw, and goes from the radial artery, and it sits in the innominate and the carotid artery while you are doing your procedure. At the end of the procedure, you remove these filters, and this is how it looks fluoroscopically, that it is a filter that is sitting inside. And if you remove this filter, you can see that inside of the filter, you catch all kinds of material, including calcium clot, catheter fragments, all different things that you can catch in the filter. And there are more than two, but at least two published randomized trial information available to us. The CleanTAVI was the first randomized trial done in Germany. And as you can see here, there are 50 patients in the filter group and 50 patients not in a filter group. And these patients were followed very systematically by a MRI done before and MRI done within 7 days of the procedure. And the primary endpoint was to see that you see less lesions by the MRI. And there was also some neurocognitive analysis done. But again, this is the early experience where what exact neurocognitive analysis has to be done was not very clearly defined, but this was also done. And if you look at this, with the help of this neuroprotection device, there was decrease in the volume of the lesions inside of the brain. As you can see, the filters decrease, the more than 50% decrease in the amount of volume that goes in the brain. And if you look at all the infarcts that happened in the control group without filters and all the infarcts that happened in the patients with the filter, there was a definite difference. The difference is there is some filter-related infarct also because we have to insert a material inside of the brain, and one artery is not covered by this particular filter, which is the left vertebral artery, because we put it in the carotid and the innominate, so the left vertebral artery is not covered. So that's why in the posterior circulation you see some strokes. As I said, that there are several different levels of evidences available, from the first-in-man to histopathological studies where we collected the debris, the CleanTAVI that I presented. The Mistral is another trial that is going to be a late-breaking trial presentation in the October meeting. The Sentinel trial is a trial that we are doing in the United States where we are randomizing people with and without the filter device with the TAVR and doing neurocognitive analysis and MRI, and also checking the safety of the device. And the Sentinel-H trial, again, a similar trial in Europe. So the idea is that the the emboli at the time of TAVR is a very important piece, clinically relevant, important not just to the physicians but to the patients and the family, and a very important piece for us to track in the future, because people undergo surgery or TAVR depending on where the stroke is going to be less. So in order to understand, in order to provide a better information, tracking this particular outcome is so critical for the field in general, and for advancement of the TAVR technology as well as for the neuroprotection technology. And that is the most important message that I wanted to convey. Thank you.
Does anybody have any clinical questions for Dr. Kapadia? No? Okay, we'll go ahead and move on to the coding options. And before we get started on that, I just would like to point out that this is a new technology application. They will be submitting an application for this November for the next fiscal year. On page 18, we have current coding, and as we stated, there is currently not a PCS code to describe the cerebral embolic protection device. You would just code the aortic valve replacement. So coding option 1 is not to create a new code, that you would just continue to code the aortic valve replacement. Coding option 2 would involve the creation of a new code in section X for new technology to identify the percutaneous prophylactic filtering using the dual independent filtration technique during a TAVR procedure. And then you would also code a separate code for the actual replacement procedure. So you can see in table X20 for assistance, we would add a device substance technology value of 1 for cerebral embolic filtration, dual independent technique. The qualifier would be 2 for new technology group 2. Coding option 3 involves creating a new code in the extracorporeal assistance and performance section, which is section 5, by adding a new row containing a value of 6 for circulatory intracranial, and also it would involve qualifiers 2 and 3 for embolic protection, dual or single filter. And again, with this option, a separate code for the valve replacement procedure would be reported with this option. CMS recommendation, we are interested in hearing from the audience and the public, as this is a new technology application. And in the interim, we'd advise to continue just coding the aortic valve replacement procedure, and there is no code to add for the Sentinel embolic protection device at this time.
I'm Linda Holtzman from Clarity Coding. I actually have a clinical question. I'm sorry, I hope I didn't miss my opportunity.
No.
Thank you. My question is, do you see this becoming kind of the standard with a TAVR procedure? I mean, do you foresee it reaching the point clinically where this is routinely done with all TAVR procedures?
I think a very insightful question. I'm not sure that it will be for all patients with the TAVR, but now there is a lot of evidence that there are some so-called high-risk patients where they have more risk of stroke, like having large amount of calcium, protruding calcium, arch is calcified. We require more critical aortic stenosis compared to the less critical aortic stenosis. Some evidence that older patients may be at risk, bicuspid aortic valve may be at risk. So I think that personally that it is only time will tell that whether you will use it in all patients or not. But it is very possible that people may select a more, and also you have to remember that putting these filters may also have some risk. So we may have to balance the risk benefit. So in some people who have very tortuous cerebral vessels, we do not want to put a filter because it may be difficult, or a particular device may be better than the other. But the idea is that it is unlikely, like a carotid stenting, where all the patients undergo a filter placement.
That's why I asked.
Exactly. So it's very unlikely that we will reach that level of use in this particular device.
Thank you.
And you have to also recognize, if I can, that there are TAVR is one part of a very small puzzle, because mitral clip, left atrial appendage occluders, closing the appendage, or for that matter, AFib ablation. So there are several different procedures which has a procedural risk of stroke. And it is very likely that this or similar kind of devices may be used for this kind of endovascular procedures where there is risk. For example, even the ascending stent grafts that we just discussed prior, all those things have risk of stroke. So if there is a way to prevent the risk of stroke, it's very likely. And surgeons are looking at surgical risk too. So when you go on pump, you can put similar protection devices to say that whether you can prevent the cerebral emboli during the bypass surgery. So it is very likely that you will see this penetration in different groups of treatments rather than just in the TAVR, and not in all, and maybe in a subgroup.
Thank you very much.
Sure.
Nellie Leon, she's saying American Hospital Association. I'm having trouble trying to distinguish between option 2 and 3, in the sense that option 3 creates 2 qualifiers, one for dual filter, and one for single. And in option 2, it sounds like you're only interested in the dual filter. Is that correct?
Yes.
Okay. All right. And so I guess the question was, what does independent technique mean? And I'm concerned because if that's the route we would go, the coders would need to find some documentation that would fit that, or at least to try to understand what does that mean as opposed to saying dual filter. I mean, I think dual filter, single filter, we would be able to understand what that is, but I'm not sure what the independent technique is.
Okay, so are you in favor of option 3, or do you like option 2 with the terms revised?
I'm not sure that I'm at a point to make a decision about
Okay.
that. I was just trying to kind of understand it.
Okay.
Because there's two issues. One being, do we want it in the new technology X code section versus putting it in the extracorporeal assistance? But I was just trying to figure out what does independent technique mean?
Okay.
Or is that
And
important to capture this technology?
And
Is that what distinguishes it from
maybe we
any
can
other
ask,
filtration?
Dr. Kapadia, do you have comments that you can make regarding documentation that coders might see in the record?
I think personally that I agree with you that there is nothing, because it is not a dependent technology, so everything is going to be independent. So dual filter, I myself don't see a very big why there is an independent term. I must say that I didn't study this before, but I would myself think that this is not necessary. I agree with you that the independent looks a little bit extra to me.
Okay, thank you.
Thank you. Okay, so you'll send in written comments. Do we have any other comments, concerns, or questions in the audience today? Okay, seeing none, I will turn it back over to Pat.
Thank you, Maddie. I'll ask Choma Obi to come up now. She will go through the next 2 procedure topics on our agenda and do the introduction for these. Choma.
On page 20 of your handout is the 3rd topic, intracardiac pacemaker, commonly referred to as leadless pacemaker. The issue is there is no unique ICD-10 PCS code, procedure code to identify the insertion, removal, or revision of an intracardiac pacemaker, and it's not a new technology at this time. I'll be inviting Dr. Timothy Shin for his clinical presentation.
My name is Timothy Shin. I'm Director of Clinical Electrophysiology and Arrhythmia Services at St. Joseph Mercy Hospital in Ann Arbor, Michigan. Excuse me. Disclosures would include I receive research support from Medtronic, St. Jude Medical, Boston Scientific, Biotronic, and Gilead Pharmaceuticals. I am also a consultant to both Medtronic as well as Spectranetics. Currently, pacemakers are indicated for the treatment of excessively slow symptomatic heart rates. Some of these indications for pacemakers can include symptomatic sinus bradycardia, which includes inadequate heart rates for the perceived level of physical exertion. Sick sinus syndrome, which is the most common indication in this country, which is frequently referred to as tachycardia-bradycardia syndrome. Heart block, which can be both acquired as well as iatrogenic. Excessively slow heart rates are frequently caused directly as part of the aging process, but can also be associated with underlying heart disease. When we start referring to pacemakers, nothing has really changed over the past 40 years. The pacemaker itself consists of 2 major components: the generator, which consists of both the battery and the electronics, as well as the lead, which is comprised of simple electrical wiring as well as electrodes. Typically, a pacemaker is implanted in the chest, either the left or the right anterior chest. The procedure includes making an incision of approximately 2 inches in the chest wall, through which access is gained into the subcutaneous tissue. Through that access site, we puncture into the left subclavian vein, if it's on the left side, but into the subclavian vasculature, through which the leads are slid down into the right heart chambers. They are subsequently positioned within the right atrium or right ventricle, or both chambers as indicated. Once those leads are positioned within the targeted chambers, they're sutured to the underlying tissue up in the pocket, at which point then the pocket is created by expansion of blunt dissection underneath the skin itself. That is for the pacemaker system. The leads are then connected to the generator, at which point it is now a system, and the entire device is placed into this pocket. The pocket is then sutured shut. The procedure itself hasn't changed significantly over the past 40 years. In contrast to the conventional systems, the intracardiac pacemaker is a combination of both the generator and leads in a single package. It is actually implanted directly into the myocardium. There is no subcutaneous leads. There's no subcutaneous pocket. The completeness of this system actually eliminates potential complications associated with current devices. Those complications can include pacemaker pocket infections, skin erosions, where the device itself actually causes pressure necrosis on the skin and then is extravasated out, lead fractures, which accounts for approximately 1% of all failures in a 10-year period of time, occlusion of the major blood vessels, which can result in cosmetic issues as well as lack of vascular access, especially in those patients undergoing hemodialysis. And lastly, but in many ways most importantly, chronic pain. The intracardiac device itself is a beneficiary of computer technology as well as miniaturization. What it has allowed us to do is to combine both the leads as well as the generator into a single package. The electrodes are still present. The device itself functions as an electrode, or one part of the electrode. The units themselves are quite small. They are on average of about the length of a quarter, slightly larger, 20 millimeters and 40 millimeters. Despite, once again, the fact that they've commonly been referred to as leadless, really the part that's missing is the wires. The electrodes and all other components are still present. Implantation of the device is very different. Currently, the intracardiac pacemakers are implanted via the femoral vein, either the left or right femoral vein. Access is gained percutaneously directly into the vasculature, at which point then a delivery system is advanced to the right heart chambers. Once the delivery system is advanced to the right heart chambers, under fluoroscopic visualization, it is crossed into the right atrium, through the tricuspid valve, and into the right ventricle itself. The device itself is then affixed to the myocardium. It is checked, what we call tethered, and at which point then it is reprogrammed. And once it is reprogrammed, the delivery system is removed from the heart, and the device is abandoned directly within the myocardium itself. It is now fully functional and within the heart chambers. As with all implanted devices, they are battery operated. And as they are battery operated, they will eventually need some type of replacement. Currently, the implanted intracardiac devices can be removed either by snaring the device and then extraction with implantation of a new system, or the old device can actually be inactivated and a new device implanted. Because of their very small size, the devices themselves should not impact heart function, nor will they occlude the ventricular chamber itself. And once again, as with all hardware, an infrequent complication with pacemakers is dislodgement of the device. Currently, if a pacemaker lead is dislodged, that device can occur, or that dislodgement can occur both acutely as well as chronically. And what that requires is revision or repeat surgery and replacement of the lead or repositioning. The intracardiac device is very similar. If there is dislodgement, and it will tend to be acute, the device itself can be re-snared, and then revision can be performed. The revision may consist of simple repositioning of the device and redeployment. In some instances, it will require extraction of the device and then placement of a new unit. Once again, this is all done under X-ray. It is anticipated that this device will be implanted in both an inpatient and outpatient setting. Currently, approximately 50% of all pacemakers in the Medicare population are implanted in the inpatient setting. Required heart equipment will be fluoroscopy in its deployment, as well as surgical sterile conditions. When we start talking about how to differentiate these devices and the implantation techniques, I think the important things to note is, number one, there should be documentation someplace within the operative report that you are either placing a, quote, leadless, unquote, system or a, quote, transcatheter system. Of note, there will be nothing about leads in the surgical report. Secondly, the access will no longer be in the chest. It will only be from the legs at current technology levels. There should be no evidence of a pocket or an incision made in the chest. And interestingly, there's actually no suture. So if you see documentation of suturing, it should raise a question as to whether or not a truly leadless device was implanted. Currently, it is anticipated that we will have 2 leadless pacemakers available in 2016, and that is both the nanostim as well as the micro devices. When we start looking at the future, many of us have looked at leaded or wired pacemakers, conventional pacemakers that are having severe limitations. Those limitations have to do with the wiring itself, which is the weakest link. If you think that your heart contracts on average 100,000 times a day, and these current pacemaker leads are lasting 10 to 20 years or anticipated, you can see what the torsional forces on these wires are. As we've all been hit with these alerts or recalls, however you want to look at them, with wiring, as we try to refine our wiring technology, we start running into some of the limitations. One of the things that we've not looked at specifically in the past was, well, what about replacement time? Because we've routinely reused the old wiring and just changed the generators. And we now know that the generator replacement using old wiring is actually of much greater risk than putting in a whole new system, which took everyone by surprise. And so that has driven everyone to use longer lasting devices to minimize reimplantation or generator replacement. So the future may very well be more and more systems without having hardware. Currently, we only have single chamber devices available for the ventricle. It is anticipated or projected that we'll have dual chamber and possibly multi-chamber devices available in the future. As these units get smaller and progress, that is a greater and greater likelihood. When we start looking at those patients who would benefit from this as soon as it is widely available, we're going to be looking at patients specifically who have limited vascular access, or as the nephrologist would term it, GOLD. The GOLD in them has to do with vascular access because you can't get hemodialysis without it. And anytime we put a lead in, we lose one site of vascular access, or we threaten a site of vascular access. So this will be a device which will most likely be the standard of care for patients on hemodialysis. That is one group of patients which right now are very underserved from a cardiac and specifically cardiac device industry side. So why is it important to have the ICD-10 PCS code specifically for the implanted device? It's really going to be very important in terms of the flavor of what ICD-10 is all about and allowing us to track outcomes based upon large populations and data use and data analysis. We'll be able to look at different rates of utilization of the leadless system compared to a conventional system. We'll be able to data mine further and look at complications associated with each one, and this will all be then outcomes-based medical care. This should help give us meaningful data to derive evidence-based clinical recommendations versus so much of our recommendations which are, quote, expert opinion. So, any questions?
Are there any questions, clinical questions or comments for the physician? Please step up to the mic. Thank you, Doctor. Right now, we'll go on to the coding from page 20 on your handout. I'll go over the coding options. So while we wait for the slides to come up, okay.
I have a question for the doctor.
Okay.
I'm not sure if this is a facetious question or not. I'm Muriel Adams, and I'm a consultant. The question I have is, there's been some discussion out in just the general literature about hacking into some of these types of devices. So I was just wondering if you had any comments about that.
It's an interesting thing about hackability. I think the very first data that came out about hackability or communication within was actually from the state of Michigan. And it was an interesting thing. The way it was presented in the lay press and some of the medical press was relatively inaccurate. The device itself required that it actually be hooked up to the programmer, and hooked up to the programmer on, everything activated and filters wide open, and then it could see communication. So the industry has done a very good job of trying to make these devices as, quote, unhackable as possible. I think you know, the FDA, in terms of what we're going to term as wireless connectivity, is taking some very stringent and very tough measures in terms of trying to prevent these devices from being, quote, hacked. I think there was a CSI episode where they actually hacked a pacemaker, the person died. So I'm not sure that there will be hackability. As the devices themselves become intercommunicative, in other words, they communicate within the heart themselves. And what I mean by that is the dual chamber and the multi-chamber. They will actually at least still be without wiring, which means that they're going to have wireless communication in and of themselves, between themselves. Now, I'm not a computer guru, so I can't tell you that they couldn't hack into that. I'm sure somebody could. But at this rate, it really comes down to is what's the possibility, what's the sensitivity, and more importantly, can it be done in terms of extraneous noise and isolation and the safeguards they're implanting. I think one of the things that we forget is that when we start talking about hacking into anything, and they talk about Chrysler and being able to hack into their ECU, is that software is widely available. That is nothing that is a tightly guarded secret. That is a very widely available software program, to the point where every day someone is hacking into the manufacturer's software to upgrade their car. That's not a widely acceptable software from the manufacturers. And I'm sure that if somebody wanted to spend the time and gain access, they could figure out the software language and all of that, and it could be done. But I don't foresee that it's going to be especially a problem.
We're going to go over the coding options. The current coding is to use the device value D, intraluminal device, and the root operations, insertion, removal, or revision on tables 02H, 02P, and 02W respectively, as appropriate for intracardiac pacemaker procedures. Pacemaker interrogation using table 4BO. And these are the slides for each of the tables. 02P, the removal. 02W, revision. I'm sorry, and there was 02W at the end for the revision of the intracardiac pacemaker. Coding option 1 is not to create new codes. Just continue using the codes listed in the tables above. Coding option 2 is to create a new device value N intracardiac pacemaker for the related body part values that currently exist in tables 02H, 02P, and 02W for the device value cardiac lead. These are the tables. Coding option 3 is to create a new section X code for the root operations, insertion, removal, and revision with the device value N, intracardiac pacemaker, body part value K, ventricle, right, and the approach, percutaneous. And these are the tables for that. CMS recommends option 2, to create a new device value N, intracardiac pacemaker for the related body part values that currently exist in tables 02H, 02P, and 02W for the device value cardiac lead. In the interim, would advise to continue using the codes listed under the current tables. Are there any questions or comments regarding the coding options? Please, could you step up to the mic? Turning on page 24 of your handout is the fourth topic for the day, endovascular repair of abdominal aortic aneurysm via entire sac sealing, known as EVAS. Currently, there is no ICD-10 PCS procedure code to describe the use of entire sac sealing abdominal aortic aneurysm repair procedures from other endovascular abdominal aortic aneurysm repair procedures. And so the question is, would a new code be created? Our presenter for the clinical piece is Dr. Jeffrey Carpenter, and he will be taken up from here.
Very good, thank you. Well, it's a privilege to be able to address this important group. And you're getting a complete course in cardiovascular surgery this morning, and I think you'll all be ready to sit for your boards after we're done. By way of introduction, I'm a vascular surgeon, department chairman at a medical school in the Department of Surgery. I've also served formerly on the Society for Vascular Surgery Coding Committee that Dr. Seidman now chairs, and was on that committee at the very busy time when endovascular aneurysm repair was just being introduced. There was a lot to do. I've also been a device inventor and entrepreneur, and Dr. Seidman actually, I was surprised. I saw a slide of his with a branch graft, which actually was based on my patent, and I was very flattered that he would present that this morning. So Dr. Seidman handled this very well. This is the basic background on aortic aneurysms. We know that this is basically a bubble that forms in the aorta as it degenerates, and like a bubble, if it gets too big, it'll burst with catastrophic, was the word he used, results. It's the 13th leading cause of death in the United States. Some very famous people have died of ruptured aneurysms: Albert Einstein, Lucille Ball, George C. Scott. So it's a significant health problem. Most patients are unaware that they have an aneurysm and are asymptomatic, and they either find out at the time of rupture or usually by a test done for something else, a gallbladder, an ultrasound, or CAT scan for abdominal pain, something like that, and they're found to have an asymptomatic aneurysm. The treatment options you also had rehearsed this morning. First is to watch and wait and do nothing other than observe, because we don't repair the aneurysms until we cross that red line at about 5.5 centimeters. So for those patients, they just undergo annual or 6-monthly surveillance, usually with ultrasound or some kind of CAT scanning. When the aneurysm becomes large enough to repair, it's treated either by open surgical repair, as was described, or by endovascular repair, which has become the most prevalent method. Now, the open repair is an extremely durable method of repairing aneurysms. Once I repair an aneurysm by open method, opening the patient, replacing the damaged section of aorta with an artificial graft made of Dacron that I sew in by hand, I can say goodbye to that patient a few weeks later in the office, and we never need to meet each other again unless there's some problem that arises, which is a very unusual situation. On the other hand, the endovascular aneurysm repair, while it has less mortality up front, immediately in the perioperative period, has a much higher long-term need for follow-up because the results are not nearly as durable. And that is something that we're learning about endovascular aneurysm repair that has caused great concern in the vascular surgery community, and that's why new methods and improvements to existing methods need to be and are being developed aggressively. The endovascular method we do by exposing the arteries in the groin rather than a major invasive body cavity operation in the abdomen. And with that, we can even do it under local anesthesia with our patients awake. We repair the aorta by inserting a sleeve or a liner, as you know, from the inside, and then the patient usually goes home the next day. They do require aggressive surveillance, though, because there are things that can go wrong that don't go wrong with our open repair. That is, the devices can move, which we call migration. The devices can develop leaks, or the individual pieces can come apart, repressurizing that aneurysm sac and leading to rupture. And these things all require aggressive surveillance. Now, the most common reason to need to re-intervene on a patient, and the re-intervention rate is quite high, about 1 in 15 patients, or maybe even as high as 1 in 3 in some recent articles. The root cause of this is the problem of endoleak. And that's why I want to educate you briefly on endoleak and what it is. Endoleak means that there's some way of repressurizing that aneurysm sac that we thought we were occluding or excluding by the endovascular aneurysm repair. So the leaks have been described in 4 different types. Type 1 is when the actual seal that's created breaks down. It depends on a watertight gasket, if you will, at the top and the bottom to keep blood from flowing in this sac. And if there's some defect in these seals, that's called a type 1 leak. That occurs in about 1 to 7% of leaks. Type 3 is when the tinker toy pieces that have been assembled inside pull apart. As the aneurysm is excluded, it shrinks. That changes the geometry. When the geometry changes, it can lead to pull out of pieces, and that has this prevalence, 0 to 2%. Type 4 is if you actually develop a defect in the fabric of your endograft has famously happened with one of the older devices, and that also is rather uncommon. The main type of endoleak that we encounter on a daily basis is type 2. Now, one thing that we don't do in endovascular repair that we do when we perform open repair is we open that aneurysm up and we sew off all these little branches that are inside the sac. Mentioned earlier today was the inferior mesenteric artery. That's a big branch that sits right about here in the sac. There are many lumbar arteries coming off the back. And whereas we put sutures in those when we do open repair, we just hope that they're going to occlude themselves when we do endovascular repair, and they don't in a lot of patients, which leads to blood flowing backwards back into this sac. That's type 2 leak, and that is our major concern and what leads to the most reinterventions after endovascular aneurysm repair today. So all of that is by way of introduction to entire sac sealing. Is there a way to fill up that entire sac so that we could spackle shut all of those endoleaks and grease those gaskets at the top and the bottom so that they would be permanently sealed in the entire sac? The entire sac sealing procedure is distinctly different from what we are currently doing with endovascular aneurysm repair. There are 4 steps, and I'll briefly go through them with you. The first step is a very simple step of inserting a wire up from the groin through the aneurysm and placing stented grafts over top of the wire, typical of what we're all familiar with in a kissing balloon, kissing stent fashion. The stents are aligned and then they're deployed. The next 2 steps, however, are unlike anything else that we do in endovascular surgery currently, and that's to seal the sac. If you've ever gone to the hardware store, there's a product there called the Great Stuff. Has anybody ever bought the Great Stuff? Yeah, you know it. It's great, right? And you squeeze it out like shaving cream, and it fills up a space, and then it hardens. And that's what we want to do in entire sac sealing. These stents that we put in over here had wrapped around them plastic bags, polyurethane bags. And we can expand those bags first with saline so that they unwrap off the outside of the stent, fill up that entire space, and then we evacuate the saline back out after the bags are unfurled. And then finally, we fill those bags, now unfurled, with a polymer that hardens like the Great Stuff. It fills the entire sac. It seals up all the attachment zones to eliminate type 1 leaks. Type 3 leaks, they can't be pulled apart. It provides the stabilization so that the graft can't migrate. And also it spackles shut all of those branch arteries that lead to type 2. Here's a little more detail on what the system looks like. This is the system as it comes out of the package. You see a delivery system, and here's the stent with the bags wrapped around the stent. And when you open the bags up, this is a magnified version of this area here. It looks like this, and these bags come off and get filled with the polymer. All of the manipulations are done at this back console for arteriography, inflating the stents, adding the polymer. The future concepts to go beyond what we're doing currently with endovascular aneurysm complete sac sealing is that we could move even higher, as Dr. Seidman was describing with fenestrated and branched strategies. We've started looking at the infrarenal aorta below the renal arteries. Here's an aneurysm like he was showing that goes up to the area around the renal arteries. And now branches have been added going out into the renal arteries. You could imagine they could also go out in the celiac or superior mesenteric artery. And now that polymer, if I move these bags up, could seal the entire area, all the gaps around those various tubular stents to completely exclude the aneurysm and prevent flow from getting down in here. So that is an anticipated strategy to extend sac sealing even further. Here's some data on this problem of endoleak, which you recall I said is the main culprit in stimulating the need for reinterventions. With complete sac sealing in the NELIX registry, the endoleaks present at 12 months are minuscule, 0.7%. The most recently approved graphs are actually shown at this end here, and you can see much higher endoleak rates with them. So this new technique, adding these additional steps to our procedure, has dramatically impacted our results. Secondary interventions also have been dramatically reduced by the introduction of entire sac sealing into our armamentarium. So what is the status of this? Entire sac sealing is currently CE marked and commercialized in Europe since 2013. In the US, there is an IDE pivotal trial underway, of which I'm privileged to serve as the global principal investigator. We expect FDA approval in the early third quarter of 2016, so early in the second half of 2016. The initial indications are expected to be for the treatment of infrarenal aneurysms with suitable anatomy, as included in the IFU. But there are future pursuits for expanded indications like the juxtarenal and pararenal chimney snorkel branched technologies that I showed in that prior slide. The key points that I would like to get across to this group are on this slide. Entire sac sealing can be directly identified within the procedure report and from the event log. It's very clear that this is something new, different, and identifiable from reading that procedure or operation note. The context in which this occurs is endovascular sealing of an abdominal aneurysm. So you will find in the note terms like a sealed sac or an endobag, which is a component that doesn't exist in any of our other endovascular aneurysm repair procedures. Polymer-filled sac, something that doesn't happen with any of our other devices or procedures. Endovascular aneurysm sealing, EVAS, endovascular aneurysm sealing. These are all terms that would stand out in the procedure and operation notes to identify the procedure as such. Use of the NELIX device or EVAS would indicate entire sac sealing. Now, as a clinician and as an academic clinician and scientist, and as a concerned vascular surgeon, I'm very interested in the outcomes for our patients. And the introduction of a new code would dramatically impact our ability to use administrative databases to track the progress of this new procedure and its result and impact for our patients. If it's just lost in the current EVAR coding, we lose that ability to distinguish and call that out. And I think that's a disservice to our patients. So tracking and measurement of utilization of the procedure and clinically looking at our outcome results so that we can make improvements and do the best things possible for our patients based on knowledge from administrative databases. Creating unique code values to differentiate entire sac sealing from open surgical repair in EVAR patients permits clinically meaningful outcome analysis. Well, thank you for your attention. I'd be happy to take any clinical questions.
Thank you, Doctor. Any clinical questions or comments for the physician? Please step up to the mic. We're going to go to the coding options. So from page 25 of your handout, we'll be going through the coding options. The current coding, there is no ICD-10 PCS procedure code to distinguish the use of entire sac sealing endovascular abdominal aortic aneurysm repair procedures from other endovascular abdominal aortic aneurysm repair procedures. The appropriate codes from table 04V would be assigned. And that's the table right there. Coding option 1, do not create any new codes. Option 2, add a new device value, G, intraluminal device, entire sac ceiling to table 047, restriction of lower arteries. This option allows identification of the ceiling beyond the aortic bifurcation in the common iliac arteries and also reflects the proposal to add the qualifier value 6, bifurcation. That's the table there. Coding option 3, add a new code for EVAS to section X, new technology, under body system 2, cardiovascular system. This option allows the ability to identify this technology separately, regardless of whether or not a new technology application is submitted. CMS recommendation, we recommend option 1, do not create a new code at this time. It's CMS position that it's too early to fully evaluate and consider this request for a new technology. And the requester would be submitting a new tech application not until November 2016 for a 2015 fiscal year 15 consideration. And we also note in the background section of this topic that NILEX EVAS will be used in the thoracic aorta in the near future. According to the requester, it's also expected that NILEX EVAS device with fenestrations will be developed, which would eliminate the need for snorkels and chimneys. So we will recommend that this proposal be brought back for further discussion at a future ICD-10 Coordination and Maintenance Committee meeting when more information is available regarding this technology. Any questions or comments regarding the coding options? Please step up to the mic.
Nellie Leon, Chisane American Hospital Association. Given the large number of codes that we expect next October, this looks to me that it's a little bit ahead of time, especially since you don't have FDA approval. Option 2 would create a whole bunch of codes in areas of the body where the technology isn't going to be used, and the fact that things may be changing with the technology, I support CMS's recommendation to not do anything at this time.
Thank you, Nellie.
Good morning. Tom Meskin, representing Endologics. Just to be absolutely clear, as it relates to the AAA aneurysms, we do expect approval in the early part of the third quarter of 2016. The backgrounder does reference a variety of other potential applications. Those were input into our request because we know that this committee has an interest in consistency of approach, and we were aware and participated in the fenestrated and branch proposal. So we wanted to provide the agency and this committee with the information that in the future, not in the future, potentially the NELEX device might come into play. So from our perspective, it's the current abdominal aortic application that is at play here. We had references before to evidence-based medicine. Dr. Carpenter spoke eloquently about that, and the danger becomes we have a novel approach which has substantially different clinical outcomes. that will hit the market commercially, become commercially available sometime in that second half of 2016. And I think we're all familiar with the fact that in the early stages of early adoption in the commercial area, that's where some of the greatest learning is. And so if we delay creating codes, we're going to fail to capture the use of this procedure at its earliest stages, which in some ways may be very informative, certainly would be informative. Obviously, there's long-term results as well. But to catch it sooner rather than later seems to make a lot of sense. And then finally, I had a question for you, Shioma, which is on option 2. In your option there under interluminal device, add G, you just have sac sealing. I assume that's a typo, and it should say entire sac sealing.
It's entire sac sealing. It's written there, add G intralunar entire sac sealing.
Okay, so the version I have didn't have that, so that's great. Thank you.
Thank you, Thomas. Any other questions or comments? CMS would also like to solicit recommendations for an alternative language to be used regarding the word entire within the entire sac sealing technology. We welcome any comments written and any comments right now on an alternative recommendation for this word. Thank you.
Thank you very much. We'll now move to our last topic, procedure topic of the day, and we'll ask Rhonda Butler, 3M, she's our contractor, to come up and go through some proposed updates to addendum and the key updates.
Thank you, Pat. This will be very brief because it was a quiet update cycle for addenda. The first is the body part key addenda. So we had a recommendation to add that the body part, the base of the tongue, is cross-referenced to the pharynx body part in the ICD-10 PCS body part definitions. Next, we had some device value, device manufacturing terms added to the device key. These recommendations include several devices from Cook Biodesign, fistula plugs, hernia grafts, layered grafts, etc., to cross-reference to the device value non-autologous tissue substitute. And last but not least, a small change in the index. Under the main term arterioscopy, it was going straight to the available code without any information about which body system that code would go to. And so to assist coders who don't have all those body systems memorized, it shows you which table you would go to for an arterioscopy of the great vessel or the upper artery or the lower artery. And that's it. Any comments or questions about any of those proposed changes? All right, Pat.
Thank you. That concludes our part of the meeting, and I'll repeat one more time on all these procedure topics. We need your written comments by November 13th. I'll now turn the meeting over to Donna Pickett, who I said earlier will continue for the rest of the day until 5 o'clock this evening, and then she will be picking up at 9 a.m. tomorrow morning with any remaining topics. So Donna Pickett.
Before we launch into the diagnosis presentations, we're going to do a 10-minute break to allow us to regroup and for everybody to take a short break. So please return in 10 minutes.
I'm sure it's been a long week for you. Huh? All right. No, she's wearing. What's your? Do you have any idea by any chance? She said that we needed. Oh, we are.
Yep, is I mean you're like one of the first ones.
Oh, okay. So even. Oh, so I thought if.
Except if we go fast.
Well, that's what I was saying.
And you may want to touch base with her because I know that we are ahead of schedule like 40 minutes or so.
Right. Well,
So
that's why
at
I
the
was.
time-
That's why I was wondering. So you have some before us though. So
We're going to
diagnosis.
do 3 ophthalmology, 1 hepatic encephalopathy, and then you guys actually you may get bumped up. I was going to see if we can catch up with her, but I know it's slated for the first after lunch, but we are ahead of schedule, so
Okay.
potentially we could go earlier.
Okay.
All
Well,
right.
thank you.
Okay, we're going to restart. I will dispense with announcements. Pat covered pretty much all the announcements that I normally would make on the second day, and since this is the first day, I get to piggyback on Pat's remarks. Again, key point is comments on the proposals are due by November 13, and new proposals for consideration for the March 2016 meeting is January 15. So please keep those key dates in mind. With that, I am now going to turn the presentation over to Shannon McConnell-Lamptey, who will introduce the topics and also introduce our speaker.
Good morning. Our first three topic proposals today are from the American Academy of Ophthalmology. And if you'll turn to page 16 in your topic packet, we will begin with our first topic, amblyopia suspect. But we have a speaker here that will cover the clinical background. So if you please welcome Dr. Michael Repka from the American Academy of Ophthalmology. If you can come up here, please, sir.
Yeah, sure, thanks. Good morning, thanks very much. I'm Michael Repka, American Academy of Ophthalmology, a pediatric ophthalmologist here in Baltimore. This proposal is to expand the section of ICD-10 codes on amblyopia. There is a group of children or of patients that have the diagnosis of amblyopia, but it cannot be confirmed. Conventionally, the confirmation of the diagnosis is made by a determination of visual acuity in both eyes. However, children under the age of 3 or 4 years, or patients with inability to respond to conventional visual acuity tests cannot be diagnosed definitively. So today, they typically are diagnosed as a guess with the particular code chosen as a best guess. To try and bridge the area so that it's not being a guess, but rather to have a code that is a guess, we've proposed addition of a code set, amblyopia suspect, which would be for those patients with risk factors, but the inability to clinically confirm the diagnosis. In the ophthalmology section of ICD, a similar code set exists for glaucoma, in which the patient will have a risk factor, but not the definitive diagnosis of the disease. This sort of closes a loop for patients who are screened with risk factors, but the diagnosis cannot be confirmed because they cannot do the testing that's necessary. Shannon?
Thank you, Dr. Repka. Are there any clinical questions for Dr. Repka before we look at the proposed tabular modifications? Okay, hearing none in the room, I'll go ahead and go over the proposed tabular modifications. And this is at category H53 for visual disturbances. And we are proposing at subcategory H53, amblyopia x anopsia, to add a new subcategory, H53.04 for amblyopia suspect. There we will be adding 4 new codes to capture the right eye, left eye, and bilateral, those codes being H53.041, 0.042, 0.043, and the 4th code to read H53.49 for amblyopia suspect unspecified eye. Are there any comments or questions? Okay. So as previously stated, there are 3 topics from ophthalmology, so we will move on to page 28 in the topic packet. And the topic is Encounter for Examination of Eyes and Vision with Abnormal Findings. So I'll let Dr. Repka come up and provide some clinical background on that topic.
Thank you, Shannon. Similar disclosures. This one's brought forward to produce symmetry in the vision screening space with what there is in the auditory or hearing space in terms of the screening codes. vision screening is a requirement of HRSA and of Bright Futures on an annual basis, and the current code set did not actually explain in the same level of detail why that encounter occurred, and so that you would see addition of codes, just as I said, that mirror what's in the ear space or in the hearing space for following a failed vision screening, which is important to detect whether that service is being done. That's a performance measure for pediatricians as well as to document if there are other abnormal findings, which would of course be coded separately, but calling attention to the coder that those are occurring.
Okay, so we're on slide 22. Once that slide comes up, we will, were there any questions for Dr. Repa before I go into the proposed tabular modifications? Okay. So the proposed tabular modifications are at category Z01, encounter for other special examination without complaint, suspected or reported diagnosis. At subcategory Z01.0, encounter for examination of eyes and vision, we are proposing to add a new subcategory to read Z01.01, encounter for examination of eyes and vision with abnormal findings, with the following two new codes. One, Z01.010 for encounter of examination of eyes and vision following failed vision screening, and the second code, Z01.018, to read encounter for examination of eyes and vision with other abnormal findings, and the code note use additional code to identify abnormal findings listed as well. Are there any comments or questions on this proposal? Okay, I will move to the third proposal today from the American Academy of Ophthalmology, and that's slide 50. And for those that have your topic packages, that is page 56. Again, this topic is non-exudative aged macular degeneration, and Dr. Repka will come back.
This one may be confusing only because we're commenting on a set of ICD-10 codes that were actually approved by the Committee on Coordination and Maintenance of ICD-10 a few years ago, yet which won't be published or won't be acted upon until October of 16, so next year at least I'm assuming. The purpose of this is that in the years while ICD-10 was festering in planning and production and whatever else it's been doing, medicine has gone forward. And one of the things in age-related macular degeneration is understanding the difference between two forms of macular degeneration that are not currently as glamorous as that for which all the injections are being given for exudative macular degeneration, but on the other side of macular degeneration, the so-called dry form, which affects far more people in this country and causes much more visual loss. In that section, in ICD-9 and in the form of ICD-10 that rolls out next week, there's one code. The committee approved expansion to 3 levels of code a few years ago, as I mentioned, early, intermediate, and advanced. This proposal moves geographic atrophy, which was previously included in intermediate and advanced stages, into a category of advanced. The reason geographic atrophy is important is that is is devastating to vision, and it's more properly called advanced than intermediate. So largely this is a change to move geographic atrophy to that advanced form. That certainly has coding implications. It probably will have treatment implications, and of course certainly has visual function implications for the patient that are separate than what it might be under the current situation, or at least the current as of October of 16 situation. In any case, just remember that this is in the setting of the most important irremediable. This is visual loss that can't be corrected with any of our really vision-saving surgeries that are going on or injections. Thanks.
Okay, any questions for Dr. Repka before I move over to the proposed tabular modifications? Okay, we're still on slide 50. Yes, okay. As Dr. Repka mentioned, this is a proposal where this actually was presented in the September 2012 CNM meeting, and it is currently tentatively scheduled to be in our addenda the following ICD-10 implementation. So that being said, there were two characters here under the note. One of the following 7 characters is to be assigned to codes in subcategory H35.31 to designate the stage of the disease. And the proposal is to revise one of the 7 characters, 3, to read advanced atrophic without subfoveal involvement, and also to add an additional possible 7th character, 4, to read advanced atrophic with subfoveal involvement. So are there any comments or questions for this proposal that is still pending because it is in the queue for the accepted tabular addenda?
I actually have a question. Would the term advanced dry stage just never be used, or would there be some physicians that may not have caught on with the change in the definitions that could potentially use the old terminology?
What a leading question.
Because with coders, we want to sort of see that kind of documentation, and if I accidentally see advanced dry stage, I'm going to have to send a letter to coding clinic, which I don't want. So just trying to kind of make it clear for the coders.
I would be agreeable to some kind of parenthetical or subclassification to include the word dry for both of those categories. I mean, that seems fine. That is for the proposal X3 and X4. I wouldn't make it the parent descriptor because we would like to move physicians to a more contemporary coding scheme.
Because the word dry is also used at the subcategory level, H35.31. It says dry age-related, but it doesn't say stage. You know, we coders are very literal people.
Yeah, so I think that as I look at that, the dry probably would not be typical, although I can ask Dr. Ferrara, who's a retina specialist who joined us, whether she wants dry in those lower levels. I mean, I would tend not to, but...
even an index entry just to kind of point users
most
to the
agreeable
right code
to index entries. Yeah.
If it's going to contribute to clarity in a better approach, we can remove the dry.
Well, actually, she would like it there.
So the point of dry means not exudative. So age-related macular degeneration has an intermediate stage, which is characterized by drusen. And the term dry relates to drusen, the presence of drusen. So in the old classification, dry was confounded with geographic atrophy, which is a form of advanced. And for that reason, we propose to change to atrophic, to make a distinction between the geographic atrophy lesion and the dry form of drusen. But it's not needed.
But Danielle, the question actually is not for a perfect system, but rather to help coders who are used to the old system. So do we do a disservice by indexing this code, maybe the parent code, as dry, and we don't harm that? And I think that's what you're asking, because for 20 years people will think of dry and they'll want to put it somewhere. So we have to have it listed somewhere. So I think an index entry is perfect.
Yes.
And then we can work with the staff to try and get how we do that. But I prefer not to have it in the main definition if we can do that.
Yes.
Thank you. Thank you. Were there any other comments or questions? Okay, hearing none in the room. Thank you, Dr. Russell. I will go ahead and move to our next topic for this morning. And the topic can be found on page 39 in the topic package. It is slide 33. Topic for this presentation is hepatic encephalopathy. And our speaker here to provide some clinical background is Dr. Joe Harper with Valent Pharmaceuticals. He'll provide the clinical background, and then I'll come back to go over the proposed tabular modifications.
Hi, good morning. As Shannon mentioned, my name is Joe Harper, and I'm a PharmD by training, and I'm the Senior Director in Medical Affairs with Valiant Pharmaceuticals. I'm pleased to have the opportunity today to present to the ICD-10 committee about hepatic encephalopathy. For background on this proposal, Salix Pharmaceuticals is a specialty pharmaceutical company that submitted a proposal to ICD-10 relating specifically to the code for HE, or hepatic encephalopathy. The company I'm currently working for is Valiant, and Valiant acquired Salix in April of this year. Our product portfolio includes rifamycin, which is a rifamycin antibiotic indicated to reduce the risk of overt HE in adults, HE recurrence in adults. We submitted a coding proposal seeking revisions to ICD-10 to ensure that there are clear and precise coding exists for the HE diagnosis. ICD-10 coding for hepatic failure embeds HE into a broader diagnosis that we believe doesn't do so in a manner that makes the presence of HE accurately reflected in the progression of disease. HE appears to be equated with a coma or lack of a coma. This implies that without coma, that you refer to a patient who does not have hepatic encephalopathy, but that a patient with a coma is one who does have hepatic encephalopathy. There's no direct reference to hepatic encephalopathy in the coding nomenclature as it is now. We're concerned that the ICD-10 construct for approaching HE is confusing and could result in the assignment of a diagnosis that does not accurately reflect the patient's condition. For a complex disease, the impression in nomenclature could present a substantial setback in research and tracking of the disease, as well as claims processing difficulties where a treatment for HE is furnished, but the diagnosis of HE is not clear. So in my presentation today, I want to focus a little bit on the clinical information of hepatic encephalopathy, which is really a serious condition today and remains complex and difficult to diagnose, especially among our growing elderly population. Patients with HE present with abnormalities that often mimic other brain dysfunctions. Without appropriate diagnosis and treatment, the disease can progress from covert to overt stages and ultimately result in a patient lapsing into a coma. Proper diagnosis and tracking is critically important to ensure patients receive appropriate treatment and to aid researchers in further developing diagnostic and treatment criteria. So what is HE? Well, in 2014, just this past year, practice guidelines were developed by the American Association for the Study of Liver Diseases, and they defined HE as follows. It is a brain dysfunction caused by liver insufficiency and or portosystemic shunting. It manifests as a wide spectrum of neurological and psychiatric abnormalities, ranging from subclinical alterations to coma. The disease occurs when the liver is unable to remove toxins from the blood and is brought on by cirrhosis. Cirrhosis is caused by various factors such as hepatitis, non-alcoholic steatohepatitis or NASH, non-alcoholic fatty liver disease, and alcoholic fatty liver disease. HE may occur suddenly in patients with liver damage as toxins like ammonia build up in the bloodstream, and cause damage to the nervous system. So what was the prevalence of hepatic encephalopathy? The prevalence and incidence are linked to the severity of the underlying liver insufficiency and portosystemic shunting. At the time of diagnosis of cirrhosis, the prevalence of overt HE is about 10 to 14% in general, 16 to 21% in patients with decompensated cirrhosis, and about 10 to 50% in patients with a transjugular intrahepatic portosystemic shunt. Minimal HE, or covert HE, occurs in about 20 to 80% of individuals with cirrhosis. And in total, overt HE is projected to occur in 30 to 40% of patients with cirrhosis at some point in their clinical course and repeatedly in most survivors. Early symptoms may be mild, including changes in thinking, mild confusion, forgetfulness, but as the disease progresses, symptoms become more severe and may include abnormal movements or shaking of the hands and arms, disorientation, drowsiness and confusion, very strange behavior, often severe personality changes, slurred speech, and ultimately, in the most aggressive and final stages, is a patient will actually become comatose. The disease has a very lengthy classification system that has been developed to accurately help the hepatologists and gastroenterologists classify and treat the disease. The American Association for the Study of Liver Diseases, or the AASLD, practice guidelines provide recommendations for classifying HE. In this section, what I want to do is really examine some of these classifications to further emphasize that this disease does exist on a continuum, and that the diagnosis coding references to the presence or absence of a coma alone do not adequately reflect this disease. So the disease is classified according to the following 4 factors. There's underlying disease, the severity of the disease, the severity of the manifestations, the time course, and number 4, precipitating factors. So let's take each factor one by one. I'll try to go through those and make it as simple as possible for us. Factor 1 looks at what the underlying disease is, and the underlying disease is classified as being 3 types: type A, type B, or type C. And those are from acute liver failure, those resulting from portosystemic bypass, or from cirrhosis, respectively, so A, B, and C. Factor 2 is the severity of manifestations, and there are various clinical scales that have been used to determine what those classifications are. And the gold standard is called the West Haven criteria, which categorizes the progression of HE from grades 1 through 4. When the scales and early phases of HE are taken together, including the unimpaired phase, 6 different levels of severity emerge. The 2014 AASLD practice guidelines provide a scheme for grading HE severity and provide suggested operative criteria for each of those. I want to go through those 6 grades with you just for very briefly to show you what that symptomology is, so you can see that HE actually does evolve on a continuum and doesn't just occur in a patient with a coma. So what are those 6 grades? Number 1 is a patient who would be unimpaired. So they're described as having no encephalopathy at all or no history of encephalopathy. Grade 2 is minimal HE, and this is a covert stage of HE. And it's described as psychometric or neuropsychological alterations or tests exploring psychomotor, speed or executive functions, or neuropsychological alterations without clinical evidence of mental changes. Going on to grade 1, which is the third of these grades, describes is actually now also a covert phase, and it's described as having a trivial, I think that's a key word there, trivial lack of awareness, euphoria, and anxiety, a shortened attention span, an impairment in addition and subtraction. A patient can't add or subtract simple numbers, and an altered sleep rhythm. Grade 2. This is an overt phase of hepatic encephalopathy. Is described as having lethargy or apathy. The patient has disorientation for time. There's an obvious, at this point, personality change. They begin exhibiting some inappropriate behavior, and this is another example. Grade 3 is the overt phase. It's described when the patient has somnolence, almost somnolence to the point to where they're actually in a semi-stupor. They still may be responsive to stimuli, but they're confused and they have gross disorientation and very bizarre behavior. And finally, grade 6 is described when the patient is in a coma. So at this point, they're no longer responding to painful stimuli. Another factor to talk about is the time course of HE. HE can be either episodic, it can be recurrent, or it can be persistent. And by persistent, we mean that the pattern of behavioral alterations are always present and interspersed with relapses of overt hepatic encephalopathy. From a diagnostic standpoint, diagnosing cognitive dysfunction is not necessarily difficult, but in HE it can be challenging. At the current time, overt encephalopathy remains a diagnosis of exclusion, requiring a diagnostic evaluation and consideration of other disorders that can alter brain function and manifest in ways very similar to HE. The 2014 AASLD practice guidelines recommend diagnosing minimal and overt HE using several psychophysiological and physiometric tests that should be performed by experienced examiners. The simple blood tests checking for elevated blood levels of pneumonia on its own do not provide diagnostic, staging, or prognostic value in patients with hepatic encephalopathy. From a treatment perspective, treatment primarily is going to involve controlling precipitating factors such as dehydration, any variceal bleeding or infections, and clinicians are often going to try to first identify and treat the underlying causes if at all possible. The treatments that exist today include medications to treat infections, procedures to stop gastrointestinal bleeding, or stopping certain medications that may slow central nervous system function. Other treatments that are going to directly affect hepatic encephalopathy are going to be things like lactulose, which is used to target the removal of excessive toxins within the body, ultimately resulting in diarrhea. Also, rifaximin has been used to reduce the risk of overt HE as well. Once a patient has developed HE, the 2014 AASLD practice guidelines state that a patient is at risk for recurrent episodes of overt HE, and in fact, some clinicians are going to argue that a patient does not completely recover from an episode and continues to display minimal symptoms at all times. For patients where HE does not prove upon treatment, liver transplantation is the only and sole treatment option. So to conclude, hepatic encephalopathy is a complex condition that is often misdiagnosed in earlier phases when symptoms like anxiety, depression, and sleep disorders, which are common in other psychiatric conditions, occur. The diagnosis may be particularly difficult in the elderly, where cognition and memory may be impaired by other causes. Clear and precise coding is critically important for reflecting patient diagnosis for HE, facilitating smooth claims processing where appropriate treatments are furnished, and assisting in tracking of the disease, and aiding researchers in further developing diagnostics and criteria and treatment criteria. So thank you again, Shannon, for the opportunity to present this information, and I'll gladly attempt to answer any questions that the committee or the audience might have at this time.
Are there any clinical comments or questions for Dr. Harper?
Hi, I'm Linda Holtzman with Clarity Coding. I may have missed this in the detail that you provided, but can you describe again the distinction between hepatic failure and hepatic encephalopathy, and also where hepatic encephalopathy falls in terms of coma? From what you said, it sounds like someone with hepatic encephalopathy can either not be in a coma or be in a coma.
Yeah, so it actually starts early on in the process of cirrhosis, or when a patient's liver is beginning to fail or has failed. What ultimately ends up happening from a pathophysiologic standpoint is there's a large buildup of ammonia in the bloodstream. As a result of that ammonia, it goes and directly targets the brain, and specifically the nervous system within the brain.
So would you see hepatic encephalopathy in someone who is not entering hepatic failure? Does someone need to be at least in some stage?
They are in some sort of hepatic insufficiency and failure at the point they're typically starting to, at the point when the symptomology is being diagnosed and actually being able to be seen.
Okay, so I'm trying to get at the coding notes here.
Okay.
So someone would be, someone who has hepatic encephalopathy is by definition at some stage of hepatic failure?
Yes.
Okay. So then, and then I guess it becomes a coding question after this. Then we're also looking at coding the underlying disease. Would you also code, so you would also code some level of hepatic failure, but why does it say without coma?
Because actually, do you want me to walk through the whole thing?
yes, thank
and then
you.
we can get to the one that mentions code underlying disease as well as the excludes one. And then I welcome your comments because this was really a good one. Okay, so if no other questions, I'm going to go ahead and walk through the proposed tabular modifications. At category K72, hepatic failure not elsewhere classified, the request is to delete the inclusion term hepatic encephalopathy NOS. They're proposing at category K76, other diseases of liver, at K76.8, other specified diseases of liver subcategory, to add a new code, K76.82, hepatic encephalopathy NOS, with the inclusion term portal systemic encephalopathy. With a code also note to read, code also underlying liver disease such as alcoholic hepatic failure without coma, hepatic failure with toxic liver disease without coma, icterus of newborn, post-procedural hepatic failure, viral hepatitis not specified as hepatic coma, and viral hepatitis without hepatic coma. Also proposing to add an exclusion 1 note for alcoholic hepatic failure with coma, hepatic failure with toxic liver disease with coma, and viral hepatitis with hepatic coma. Are there any comments or questions? Or Lynn, did you want to come back to clarify that part? She will. Okay.
Laura Powers, American Academy of Neurology. And I'm sorry, we didn't see this before today, so this is kind of new. There's a disconnect here because you've got, on all the different kinds of liver disease, you've got with coma, without coma. And traditionally, in I-9, hepatic encephalopathy and hepatic coma have been together. And it really didn't matter that much until industry decides that they have a little treatment for this, that you necessarily separated them because it's a continuum of the same process. And they were used interchangeably, traditionally hepatic encephalopathy and hepatic coma, because it didn't matter. You still tried to get rid of the underlying process regardless. So when I saw I-10 to begin with, and I saw with and without coma, when I say with coma, that tells me they're encephalopathic. So not without coma didn't say, that just meant to me they had no level of encephalopathy. So if you're going to do this where you have, it doesn't make sense. If you say with coma, I would rather see you take each incident of the type of hepatic failure with coma and separate that out into the different stages. But then my second comment is this, that I'm not sure, or add hepatic encephalopathy to that hepatic coma.
Okay.
Because it's part of the same process. And when it says without coma, you're just saying they don't have any encephalopathic process at all present.
Okay.
But at the same time, I understand what they're trying to do. They're trying to separate out the severity of the hepatic encephalopathy because they've got a treatment for the less severe kind. And I understand that, but I think that we need to go back and look, and I need to talk to our encephalopathy experts about is that just a research definition, or is this something that we've been using commonly and clinically? Chances are the coders in the audience have not been seeing that West Haven criteria, or seeing the terminology that's being proposed. So I'm not sure that I'm ready for that. I can see adding encephalopathy to coma in each case of coma, but I'm not sure. And then my third point is he's talking about that there's a classification, of the 4 different stages, but then you're only really wanting to separate it into 2. And that doesn't make sense to me either.
Okay, great comments. Thank you. Thank you.
Sue Bowman with the American Health Information Management Association. I think I agree with Dr. Powers because I was confused because, part of me loves this idea because we've gotten at AHEMA a lot of requests from members who really want to see the words of hepatic encephalopathy broken out into a unique code somewhere just because it's so commonly documented that way. So they're kind of confused that it's an inclusion term under case 72, but they're kind of like, well, if he just says hepatic encephalopathy, which case 72 code should I pick? So I like that concept, but now I'm really confused, particularly since none of the excludes notes under case 76.82 even talk about the case 72 codes. So it seems like we are setting up the potential to code it 2 different ways because it's a kind of hepatic failure, so it kind of fits in case 72, but now we've got it in case 76, and I just think it's kind of confusing, so I agree with what Dr. Power said. I was also somewhat interested because a lot of people have sent me this question about why isn't there a unique code for encephalopathy. I found it interesting that the requester is, a pharmaceutical company, and I wondered where the medical specialty societies sat with this proposal and whether they agreed with how this was differentiated or they agreed with Dr. Powers that maybe there's some tweaking that could be done to make this sort of fit better within the structure.
Okay, great, thank you. I will say that we did send this over to the American Association for the Study of Liver Disease, and we are awaiting their feedback just to see how their take will be on it. Linda? I'm sorry.
Not to hit on this too firmly, but I agree with Sue, and I thank Dr. Powers for her comments as well, because I've no objection to seeing a distinct code for hepatic encephalopathy. I think I'm one of those people that's been annoying you at AHIMA, well, for many reasons, but for this one also, I'd like to see a separate code for hepatic encephalopathy. I'm just not sure that this is the structure to do it. And I find the with and without coma distinctions to be very confusing.
Okay, great. Thank you so much for the comments. And we worked on this one long and hard, especially because we did have the codes that were already there for the failure, and this was a progression, so where exactly was it going to fit? So we welcome your comments, and please send them in writing. Thank you. Are there any other comments or questions? If not, I'm going to turn things back over to Donna Pickett.
Okay, I'm going to turn the podium to Cheryl Bullock, who will present the next proposal. Cheryl?
Good afternoon. Our next topic we will be presented will include, we are going to address Clostridium difficile. It is on your topic packet, page 25. And we also have our speaker presenter, Dr. Andy DeReich. He is from Merck Disease Research Laboratories for the clinical presentation. The slide number was originally slide number 19 for our AV assistance.
That's
It's all right. It's nice to see at the government they have technical difficulties like every other conference we ever go to as well. So I will have PowerPoint slides coming up in a second, but thanks to the committee for allowing me the opportunity to present. As many of you know, C. diff, especially in this room, I'm sure everyone knows C. diff, and it's approaching concern internationally at the same level of MRSA with regards to the knowledge that even non-medical community knows what C. diff is and its consequence. So I'll wait for a second for the PowerPoint slides to come up. Thank you. Thanks for the opportunity again to speak. The current problem in the C. diff space is that the current codes, whether it's ICD-9 codes or the ICD-10 codes, has one specific code for C. diff. And the main problem with C. diff is recurrence, which is also synonymous for the coders. You may see relapse in the chart. The problem with the treatment of C. diff, and I'll go into this in a minute, is not necessarily that patients don't get better when you're on treatment. It's that within a very short time after treatment, even though you're completely resolved of the infection, the symptoms and the symptomatology comes back, and often you have to be readmitted or retreated on the outpatient space. This proposal is to ask for a specific code to distinguish both initial disease and separate it from recurrence. And this is a slide that for some reason every time we talk about C. diff, every time we get asked to present, it's always right before lunch or right after lunch. So we had to make sure we put a disease colon picture up there for you to see. So C. diff is a anaerobic organism that lives in your gut. You get it by the oral route. And in some patients, it just causes asymptomatic, and you have it, but you never know you have disease. In some people, it causes toxic megacolon and even all the way up to death. The most common symptoms are frequent bouts of unformed bowel movements up to anywhere from 10 to 20 a day, where you're kind of tied to your home because you have to be around a bathroom. If anyone ever had a viral infection at some point in your life, you know what that's about. So, and also you have abdominal pain. Sometimes you have fever, and you often have an elevated white blood cell count. C. diff has been recognized by the CDC as one of the 3 most important urgent health threats, along with carbapenem-resistant Enterobacteriaceae and drug-resistant Neisseria gonorrhea. Note, this is even higher than what is currently there for Pseudomonas, and MRSA. It is very costly to the institutions. It's the most common pathogen identified in healthcare-associated infections. Again, recurrence is about 20 to 30% of the time. I'll have another slide that shows that well, and it's very costly, as you can see on the bottom here, where it has estimated cost of about $6,000 to $9,000 per patient, and then as you get larger in the healthcare system, you're getting into the billions. This slide shows it very nicely, and that recurrence as defined, as I said before, is you have your acute symptoms of infection. You go for treatment, you get your treatment, you start to get better, usually about, depending on the treatment, between about 3 to 6 days of therapy. Therapy usually lasts about 10 to 14 days. You're completely well, you stop your antibiotic treatment, so that's called generally a clinical cure, and then anywhere within 8 weeks after the end of treatment, all the symptoms come back again. So even though the clinician did everything right, you diagnosed it, you were treated appropriately, everything is correct, the symptoms recur. And this is the main problem. And it's shown here where the initial episode is shown here. And then first recurrence, as I said before, usually is about 20 to 30% of the cases. So it's not small, that's 30%. And then if you already had one recurrence, you are much more likely to get another recurrence. And this is called multiple recurrence. And if you've ever heard in the lay press, everybody asks me about it, is that if you've heard of fecal transplants, okay, this is where this is considered for this multiple recurrent C. diff. Point on the bottom is noted, and it was similar to a presentation earlier, is that in Table 1A of the most current treatment guidelines, and there's one from the Infectious Disease Society of America, there's one from the American College of Gastroenterology, and then there's also another one from the European IDs. In the tables, they recommend treatment, and it's recommended, it tells you how to treat your first episode of C. diff, but it also, very unique in ID, it tells you what to do if you have recurrence. And I can think of no other infectious disease state where it tells you right in Table 1 exactly what to do if you recur versus the initial treatment. And this slide shows a very nice cycle. And what happens is recurrent C. diff is associated with significant mortality and resource utilization. I like the slide on the left there, which shows that this cycle of recurrence, where they get it, they have to be hospitalized, they get better, they go home, it recurs, they either get treated as an inpatient or outpatient, but depending on how severe that infection is and how the other comorbidities that they have, but it goes round and around and around. And this is commonly called a lot of the published papers talk about trying to break the cycle of recurrence of C. diff. Interestingly, there was a paper published this summer in what it showed in infection control and healthcare epidemiology. And what the investigators tried to do is they tried to identify from administrative databases a prediction algorithm tool to identify who has C. diff. And what they did first is they started with the ICD-10 code. And all the coders know the ICD-10 code, there's only one for C. diff, it's 008.45. And that performed very poorly, where it only had a sensitivity and specificity of about 50 to 70%. So what these investigators did in this administrative database is they looked at the ICD-10 code, ICD-9 codes, excuse me. They also looked at procedure codes for the diagnosis of C. diff, which is either toxin-based or molecular-based. And they also looked at prescriptions for oral vancomycin, which is one of the standard treatments to be used for the treatment of C. diff. Even though they put all those three together, they still found that the study didn't adequately predict who has recurrent C. diff. So this leads some credence for our request to have help from the coders to at least distinguish between initial C. diff and recurrent C. diff in the ICD-10 codes. This is a slide that just shows where it currently is in the ICD-10 codes. It's A04.7, enterocolitis due to C. diff. And what we show here is that there is precedent with other codes for this to separate initial disease from recurrent disease, and this is shown with tonsillitis in the top here and bilateral inguinal hernia in the others. So in summary, we ask for a separate code for initial disease and recurrent disease. We think this will help with regards to distinction. It will be consistent with current guidelines that describe this disease. It will help draw more attention, even though the CDC has identified C. diff as an urgent threat. A lot of investigation is very difficult to adequately detect how bad recurrent C. diff and what the burden is. And the other thing is that because we're at the CMS, C. diff, the average age of patients who get C. diff, the median age is 66 years old. It's because of a degree of senescence of your immune system and then all the other comorbidities, antibiotics the patients have to put the patient in the situation where C. diff will grab hold and have it. So we think this is especially important in this patient population. Thank you.
Thank you. Any questions? Clinical questions? Okay, now we're back on slide 19. In response to the proposal by Merck, the tabular modification request is as follows. For code category A04, we're there. Okay. For code category A04, other bacterial intestinal infections, we will now have A04.7, enterocolitis due to Clostridium difficile will now become a new subcategory. The proposed codes are quite simple. The proposed new codes are A04.71, enterocolitis due to Clostridium difficile recurrent. New code A04.72, enterocolitis due to Clostridium difficile initial. And new code A04.73, enterocolitis due to C. difficile not specified as recurrent. Although this proposal has been submitted by Merck, we did send it to our counterparts in CDC for clinical review as well. Yes, ma'am.
Sue Bowman from AHEMA. I'm wondering if maybe 2 codes would suffice.
Okay.
The recurrent and not specified as recurrent, for 2 reasons. One is initial also isn't specified as recurrent. And the second reason is there has been so much confusion, and I know we'll hear a lot of sighs in the audience, about the use of initial encounter for the 7th characters, and then the use
Yes.
of the word initial
Okay.
in codes throughout the classification, and those don't have the same meaning as
Okay.
initial encounter has.
Okay.
And I just think maybe it might be easier, which would also match the other section that the presenter referred to, of just recurrent and then not specified as recurrent.
Thank you. Any other questions or comments? That's it. Thank you so much.
Okay, just so the audience is aware, we're having to change up the order of the presentation. We can't go to lunch until 12:30, so we're going to continue to present some of the proposals that don't have a presenter, and so Cheryl's going to come back to the podium.
Okay, our next proposal is found on page 61, which is slide number 55, but page 61 in your proposal packet. Fantastic. This proposal is to change the excludes designation for epilepsy. In ICD-10 CM, there are multiple conditions listed as an excludes OneNote for G40, epilepsy and recurrent seizures. Some of these conditions listed as excludes 1 is clinically inaccurate. Mesial temporal sclerosis, hippocampal sclerosis, and temporal sclerosis are conditions that are most often considered etiologies and symptomatic epilepsy, but by themselves are not always associated with epilepsy. The presence of these conditions make epilepsy surgery a viable option for some patients whose epilepsy is refractory to medication. It is important to capture both conditions when present in one patient. Todd's paralysis is a manifestation occurring after a seizure. It does have some predictive and psychophysiologic significance. It is not a manifestation that is considered inherent to all epilepsy syndromes. It will be useful to capture both epilepsy code and the Todd's paralysis code for specificity. The American Academy of Neurology proposes that mesial temporal sclerosis, hippocampal sclerosis, temporal sclerosis, and Todd's paralysis be included as an excludes 2 note under G40. In addition, it was pointed out to us that there is a typographical error for the code for Todd's paralysis. So as you can see, for the tabular modifications in response to this proposal, we're basically deleting the inclusion terms hippocampal sclerosis, mesial temporal sclerosis, temporal sclerosis, and the Todd's paralysis. And we will add them to an excludes 2 note and change the code identified for Todd's paralysis as G83.84, that the 4 was missing in the original document as presented in the ICD-10 CM book. Now, are there any questions, Dr. Powers, or comments?
Hi, my name is Corwin Williams. I'm here representing the American Academy of Neurology, and as stated, we submitted these corrections or amendments to the ICD-10 for the reasons you already outlined.
Okay.
I also wanted to share that we shared this information also with the National Association of Epilepsy Centers, and they were in agreement with these changes as well.
Thank you.
Thank you.
Good. Thank you. That's another short one.
Okay, looking for other short ones that we can do. In your handout on page 15, acquired hydrocephalus. And that would be slide number 7. As some of you know, WHO, who maintains ICD-10, upon which ICD-10-CM is based, with the 10th revision also initiated an update process. And as WHO maintains and updates ICD-10, we in turn try to include that information in ICD-10-CM as well. So this is a proposal that parallels a change that was made in ICD-10 that was approved this past October. The new code is to become effective January of 2016, and the new code is P91.7, acquired hydrocephalus of newborn. It's a fairly simple change, and it breaks it out from under an other code and now provides a unique code. Again, since there have been changes in 10-CM that aren't reflected in 10, we try to make sure we always bring forward the changes that WHO has proposed, but also to bring them into ICD-10-CM to keep it current. Question, Nellie?
Yes. So this means that you no longer have a default for hydrocephalus newborn, not otherwise specified, and this actually sets it up so that it's the coder going to have to then go back to the physician and say, well, doctor, is this acquired or congenital? Because it seems that newborns, you don't really have a lot of time to figure out is it acquired because they haven't been living for that long. So is that the intent? You don't want to have a default?
Well, what we're showing here is exactly what WHO did. They do not have a default. However, there are times for 10-CM where we will include a default just to avoid the confusion that you were just mentioning, Nellie. So,
yes, please, because the coders are going to say this is going to be a lot more work, and they will need to then add to the number of queries they send to the physicians.
And I know AAP is also looking at this. I know they don't have, they're on the phone, but they don't have anyone in attendance today, so we'll be seeking their specific input as well.
Thank you.
Any other questions or comments on this proposal? Okay. Okay, we're going to look for some more for you. David, can you do megacolon? Okay.
Okay. All right, we're moving along smartly here. And we've had lots of interesting things this morning. Discussion of the types of things that can happen, and mention of things like hacking of a cardiac pacemaker and how that showed up in CSI. And I was back there thinking, I remember seeing that on NCIS or something like this. It's strange, although I'll have to admit I didn't think these shows actually showed these things in ways that were really technically feasible. But be all that as it may, let us now move to megacolon, and that is, if I can find it in my handout, it should be on page 55 for those who are looking, or slide number 49. So page 55 for those who have the handouts, and slide 49. Can we get slide 49 up? And megacolon is something that's got a number of different things that can happen. It involves the colon being significantly dilated. You can have it as a chronic or an acute problem. Basically, it's a form of an acute toxic colitis, and it can potentially be fatal or lethal. Patients with a toxic megacolon are usually very sick. Besides having a dilated colon, they'll usually have a fever, tachycardia, leukocytosis, a lot of white cells, and they may have anemia also. They'll usually have at least 3 of those 4. Now, they'll also usually have something like dehydration. They may have altered mental status. They might have electrolyte abnormalities with the dehydration. They may have hypotension. So toxic megacolon, the patients are usually a lot sicker than those who just have megacolon that's not toxic megacolon. That's the bottom line. There's a number of things that can cause a toxic megacolon, and these usually are causing an inflammatory colitis. These can include ulcerative colitis, Crohn's, pseudomembranous colitis. There's a number of specific types of infections that can cause a toxic megacolon. Species of Salmonella, Shigella, Campylobacter, Yersinia, and also one we just heard about, C. diff. You can't forget about that one, huh? Entamoeba histolytica, cytomegalovirus, rotavirus, invasive aspergillosis also can cause that. It can also be caused by other things in addition, like radiation colitis or ischemic colitis, and nonspecific colitis secondary to chemotherapy can also cause it. Somewhat rarely, a complication of a collagenous colitis, and also as a complication of Beset syndrome. Some of those are kind of rare. And certain drugs or toxins can also cause an acute or a chronic megacolon. It's proposed, given that a toxic megacolon can make someone a lot sicker than megacolon that's not toxic, that we create a new code for toxic megacolon. So looking at the proposed tabular modifications here, we're proposing that we delete the term toxic megacolon right below K59.3, and we expand K59.3, this is megacolon, not elsewhere classified, and we create a new code below this for toxic megacolon, is K59.31, and also a new code K59.39 for other megacolon or megacolon NOS. We would revise also to have this be a code first, if applicable, note to identify the toxic agent. And we would exclude the congenital megacolon and megacolon in certain other disorders, Chagas, C. diff, and Hirschsprung's disease. So. While we have the excludes one note listed there, I believe that actually is already present and is not being changed. So I may not have needed to list that, but it's just included for your information. I believe it's present already. Any comments or questions on this about megacolon?
Actually, it's a question. In the background information, you mentioned that toxic megacolon may also be caused by radiation colitis. Is that radiation from like radiation therapy, or is it something from like a nuclear accident or something? And the reason why I ask is that in the toxic agents, the radiation sickness that comes from the nuclear events, that's a T66 code, and so would not be included in your parenthetical.
Right,
so
in this list, yeah. Yeah, and that's an excellent question. I think you could get that from either one, actually. And I'm not sure how often either one of them is, of course. We don't, these days, see a lot of people with radiation from things like nuclear explosions. We're fortunate not to have that kind of problem going on these days. But there can be other types of radiation exposures that are similar to that. And certainly there's potential for exposure from radiation therapy for cancer to also affect the colon in addition. So both of those would be possible causes of it. And that is something for us to consider, that we might want to include things that are outside of that range.
Okay, thank you.
So, all right. Any other questions or comments? So we could consider expanding that range, and we will look at that further. All right. Thank you for those. Let me take a look at things. We've got a number of things we'll want to cover that we were planning to cover this afternoon, and some of those we might just be able to start on now. Donna, shall I go ahead and start on heart failure with reduced ejection fraction, or shall I start with, I could do atrial. Yeah, okay, right. That may not take me 10 minutes, but anyway. Okay, let's do hepatitis. Slide 16, please, and page 23 in your handouts. Okay. So page 23 and slide 16, here we are. The question on this has been chronic hepatitis versus a hepatitis carrier. Essentially, the idea that you can have a healthy carrier of viral hepatitis is no longer really accepted. It's considered a type of chronic viral hepatitis instead. So this change is due to the potential for a chronic viral hepatitis to be associated with hepatocellular carcinoma and also with reactivation of hepatitis to an active form. So due to the change in clinical understanding, World Health Organization has made changes in ICD-10, which are to be effective January 2016, to deactivate the code Z22.5 carrier of viral hepatitis. So as Donna had mentioned earlier, we have had some changes coming to us from World Health Organization where they are actually changing ICD-10, on which ICD-10-CM is based. And we're largely trying to follow those changes and to make the same sorts of changes to be consistent with the original ICD-10. So it's being proposed to eliminate this same subcategory in ICD-10-CM, and as well as the codes that are there. We have separate codes. We created this as a subcategory and expanded it in our earlier version of ICD-10-CM. So we are then also proposing that these cases should be coded to category B18 for chronic viral hepatitis. So looking at the proposed code changes, we have here the tabular modifications. This shows what we would do at B18. We would add at B18 chronic viral hepatitis a note includes carrier of viral hepatitis. And we would add specific notes below the codes here at B18.1 chronic viral hepatitis B without delta agent. We would add carrier of viral hepatitis B, or chronic viral hepatitis B is also there. At B18.2, chronic viral hepatitis C, we'd add a note carrier of viral hepatitis C. At B18.8, other chronic viral hepatitis, we'd add a note carrier of other viral hepatitis. And at B18.9, chronic viral hepatitis unspecified, we'd add a note carrier of unspecified viral hepatitis. And moving forward one slide, at Z22, this is on page 24 in your handouts, we would have Z22 as carrier of infectious disease. We would add an excludes note at the category level for excludes carrier of viral hepatitis to B18. And then we would delete the subcategory Z22.5, carrier of viral hepatitis, and we would delete the 4 codes below that codes Z22.50, 0.51, 0.52, and 0.59. And these were carriers of the unspecified viral hepatitis B, C, and other viral hepatitis. So, and there are also some index modifications that we would propose to make. Basically, these would all be changing, and the relevant codes, essentially the codes would go to the corresponding B18 code. So the carrier of HAA, hepatitis Australian antigen, instead of going to the Z22.59, would go to B18.8. A carrier of HB, CRS antigen, instead of going to Z22.51, would go to B18.1. Carrier of viral hepatitis, essentially unspecified, instead of going to the the Z22.50, would go to B18.9. And we spell out the carrier of the hepatitis B surface antigen, going to the B18.1 instead of the Z22.51. The hepatitis C, going to the B18.2 instead of the Z22.52. And the specified, not elsewhere classified, going to the other, the B18.8, rather than the Z22.59. And the serum hepatitis B carrier, likewise, we repeat that at the serum one. So those are current index entries we would be modifying also. Any other questions on those, or concerns or comments? All right. Seeing none, we will look at what else we have to consider here. All right. I am not, now it is now 12:28. While I could try covering something, shall we let people go 2 minutes early, or should we try to keep you here just a little longer so we could talk about atrial fibrillation or heart failure? Well, we don't want anyone's heart stopping because they're hungry or something like that, so I guess we'd better let you go, and we'll look forward to seeing you back again so we can talk about those things right after lunch, which will be at 1:30. So we'll see you here in about an hour. We'll call this foreshadowing so you know what we're going to talk about next. Okay. And thank you so much. And thank you to our AV people, Charlie and Felix. All right.